Well, good morning, everyone, and welcome to the 13th hearing of the Portfolio Committee Number 2's inquiry into health outcomes and access to health and hospital services in rural, regional and remote New South Wales. My name's Greg Donnelly and I'm the chair of this committee and inquiry. The inquiry is examining health outcomes, access to services, patient experience planning and capital expenditure in rural, regional and remote New South Wales. Before I commence, I'd like to acknowledge the Gadigal people who are the traditional custodians of the land on which the Parliament sits. I would also like to pay respects to Elders past, present, emerging of the Eora Nation and extend that respect to other Aboriginals viewing the broadcast wherever you may be today. Today's hearing is being conducted virtually and in person. I would ask for everyone's patience through any technical difficulties we may encounter. If participants lose their internet connection and are disconnected from the virtual hearing, they are asked to rejoin the hearing by using the same link as provided by the committee secretariat. Today, we will be hearing from a number of stakeholders, including mental health and advocacy groups, the New South Wales Farmers Association, Allied Health and other health services. I thank everyone for making the time to give their evidence to the inquiry today. Before we commence, I would like to make some brief comments about the procedures for today's hearing. Today's hearing is being broadcast live via the Parliament's website. A transcript of today's hearing will be placed on the committee's website when it becomes available. If, in accordance with the broadcasting guidelines, media representatives are reminded that they must take responsibility for what they publish about the committee's proceedings today. While parliamentary privilege applies to witnesses giving evidence today, it does not apply to what witnesses say outside of their evidence at the virtual hearing, or if you're actually appearing in person. I therefore urge witnesses to be careful about comments you may make to the media or to others after you've completed your evidence to the inquiry. Committee hearings are not intended to provide a forum for people to make adverse reflections about others under the protection of parliamentary privilege. In that regard, it's important that witnesses focus on the issues raised by the inquiry's terms of reference and avoid naming individuals unnecessarily. All witnesses have a right to procedural fairness, according to the Procedural Fairness Resolution adopted by the House in 2018. There may be some questions that a witness could only answer if they had more time or with certain documents to hand. In these circumstances, witnesses are advised that they can take a question on notice and provide an answer within 21 days. Finally, a few notes on hearing etiquette to minimise disruptions and assist our Hansard reporters. Can I ask committee members to clearly identify who questions are directed to, and could I ask everyone to please state their name when they begin speaking? Could everyone please mute their microphones when they're not speaking? Please remember to turn your microphones back on when you're getting ready to speak. If you start speaking whilst muted, please start your question or answer again so it can be recorded in the transcript accurately. Members and witnesses should avoid speaking over each other so we can all be heard clearly. And also to assist Hansard, may I remind members and witnesses to speak directly into the microphone and avoid making comments when your head may be turned away. So thank you for the patience of letting me work through all of that. That now leads us to the welcoming of our first witness, who is joining us remotely, and we welcome very much our first witness. So with regards to Ms. Lorvik, welcome this morning. I think you can probably or hopefully see most of us here in the room. We can see you in a big screen. We need to go through the formality of having you either sworn or affirmed to give your evidence. So if I can just be patient, I'll just go through this part of it because it's necessary. I'll get you please, Ms. Lorvik, to first of all state your full name, your position title, and swear either an oath or affirmation, whichever you prefer, the words of which should have been provided to you. If for some reason you don't have them, just put your hand up and we'll get them to you. So once again, welcome on behalf of the committee, and I'll pass it over to you.
Thank you, and I thank the inquiry for Just Reinvest New South Wales. My name is Jenny Lawbridge. I'm the Manager of Engagement and Partnerships at Just Reinvest New South Wales, and I will take an affirmation this morning.
Thank you.
So I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much for that. Now, we've just noted that Ms Judy Duncan, who was going to be joining us this morning, is unavailable, so that's unfortunate, but pass on our regards to her. So we just have you, which is great. Can I just acknowledge and thank the organisation for the provision of its submission to the inquiry. It's been obviously provided, received, processed. It stands as submission number 706 to the inquiry. It's been uploaded to the web page for the inquiry, and obviously stands as evidence to the inquiry thus far. But of course, we have you today to provide some additional material, which will become evidence to the inquiry, which will help inform our deliberations over the report and the preparation of its recommendations. So, can I invite you, Ms. Lovick, to make an opening statement? And once that's done, if you're agreeable, we'll move to questions and move between the various groupings around the table. We have representatives here from the opposition, from the crossbench, the Animal Justice Party and the Greens, and representatives from the government. So we'll share our time around with our questioning. Is that format okay with you?
That's fine, thank you so much.
Okay, over to you for your opening statement.
Thank you. As you're aware, a representative was going to give an opening statement about some people's experience of healthcare in Mori, but they're no longer available to give evidence today. So I will commence by giving an opening statement by Just Reinvest New South Wales, and then I will move over to some reflections that would collect community members, which were going to be given by that Mori representative, if that's okay.
No, thank you, that's good.
Terrific, thank you. Firstly, I'd like to acknowledge country and ancestry of the lands we are meeting from today. I personally am speaking from Gadigal country on the Eora Nation, and I pay my respects to elders past and present. I also pay my respects to the Mori people, whose experiences and reflections will be in this statement and certainly were reflected in our written submission. Again, we thank the inquiry for hearing from Just Reinvest New South Wales. The inquiry may be wondering why Just Reinvest New South Wales is interested in the area of health. Justice reinvestment in practice is about addressing the underlying issues that drive interactions with the criminal justice system and shifting resources accordingly. Health is a key driver into the criminal justice system. We are of course not medical experts, but Mori does bring expertise on local and Torres Strait Islander people's lived experience of receiving and sometimes not receiving health and hospital services in Mori. Serious disparities and challenges accessing health services and getting outcomes people want or need in a remote location will not be used to your inquiry. The people we work with in Mori are aware that undiagnosed and untreated health issues, and in particular mental health and alcohol and other drug issues, left unaddressed, result in interactions with the criminal justice system. The Special Commission of Inquiry into the drug ICE sat in Mori, and this committee will no doubt be aware of its findings and recommendations. Allegedly one of the richest agricultural regions in New South Wales. However, this largesse is not always clear to be reflected in the availability or quality of health services in Mori. Access problems are evident across the spectrum of health services, and we are told that seeing a GP can take more than 4 weeks. Most specialists are only available on a fly-in, fly-out basis, with people waiting months for appointments. Allied health services are also infrequent. As is often the case in access to justice issues, a person's postcode should not be determinative of whether or not a person can access appropriate medical treatment. Much of the focus of Just Reinvest New South's work is around young people. You know that young people in custody are nearly 6 times more likely to experience psychological disorders. The 2015 Young People in Custody Health Survey, conducted by the Justice Health and Forensic Mental Health Network and Juvenile Justice, now Youth Justice, found that over 83% of survey participants met the threshold criteria of at least one psychological disorder, and 63% for 2 or more. compared with the general population prevalence, young people, of 13.9%. We also know that undiagnosed and untreated health issues in children can be determinative of positive education, engagement and retention and employment outcomes. As we know, and we know about the pipelines of education exclusion into the juvenile justice system, with the Young People in Custody Health Survey showing over 93% of young people entering youth detention had suspended prior to entering custody. We know that sitting behind all these issues are the unaddressed impact of colonisation and intergenerational trauma from harmful child protection, removal policies and practices. Service system dysfunction contributes to a high contact with the criminal justice system. In the case of health services, silos, chronic service gaps, lack of cultural safety, and instances of racism and discrimination mean that many people's health issues are unaddressed. There is a growing and substantial body of evidence that points to racism and discrimination as determinants of poor health outcomes. We know that many of the policy and practice levers to make important systemic changes are often not directly in communities' hands, but communities we work with tell us again and again what the solutions are, and they're around community voice and community control. I may just leave my part of the evidence there and move on to the Mori community's reflections, if that's okay.
Thank you.
Great. Thank you. Mori has an Aboriginal I'll start from the beginning.
Sure.
Mori Aboriginal community have told us the families' lived experiences, the challenges of getting adequate and respectful healthcare in Mori. Mori has its own Aboriginal community-controlled health service called PIAS, and the Aboriginal community have great pride in this service for their community. But people also need to access mainstream hospital services outside PIAS. People can reflect how rich the Mori community supposedly is, but this wealth just is not reflected in access to health services. Many of the issues that come up in Mori include long wait lists to see a GP, services, including things like MRIs, orthopaedic treatment, detox, tonsillectomies. It's very expensive to travel out of town. People have to leave their jobs and their families and pay for travel, accommodation and food. If they were to take someone else to support them, that's even more expensive. Transport options are limited and it's stressful. These stresses could all be prevented if services were local. People feel they don't always get the experienced doctors that they deserve in Mori. There is a feeling that some people visiting hospitals end up leaving the hospital without adequate treatment, and some people are sent home with very serious issues that are not treated without investigations or proof. People also don't know how to complain about the poor health services they receive, and there is little trust that anything will be done anyway. People also feel they can't complain because they don't have alternatives, and they don't want to risk being viewed as a complainer and the repercussions from that. Untreated mental health and drug and alcohol issues are a big concern. People with acute mental health conditions can't get the crisis mental health they need. And this is not just Aboriginal people. There are many suicides in Mori, but it feels like these mental health issues, sometimes related to drug use, sometimes not, are not being addressed in any systemic way. We know that lots of people with mental health problems end up in the criminal justice system. Some people may have got mental health treatment when in prison, but their mental health plans and medications are not followed through when they are released back into the community. And without ongoing health treatment, they may end up reoffending and back in prison. Mental health diversions from the criminal justice system aren't easy in Mori, as there aren't enough, indeed sometimes not any, psychologists to support mental health plans. Accessing drug and alcohol services is also difficult in Mori. There is no magistrate's early referral into treatment, the merit diversion option, in the Mori local court. There is no detox service in Mori, and people are forced to leave town to detox before they can get a rehab bed. There are no specific drug and alcohol services for young people in Mori, and there is inadequate emergency department treatment in Mori for people seriously affected by drugs. When the ICE inquiry sat in Mori, a lot of people gave evidence about these issues, and nothing has been done. We also hear about concerns about the way Aboriginal people are treated by the health system in Mori. For example, some Aboriginal people sometimes feel the staff in the hospital Some Aboriginal people sometimes feel that some of the staff in the hospital in an emergency don't treat them well. Some people feel uncomfortable and judged. and that they are discriminated against. Is there a feeling that people's medical problems are regarded as self-inflicted due to addiction issues and the like? Some Aboriginal people in Mori feel staff at the hospital are dismissive and don't take their concerns seriously. There are too many stories of people being sent home with very serious conditions, and some of the people get very, very sick at home with very serious conditions. And some people, in fact, have died. Nothing seems to have been done about this. For many people, it feels like the services aren't culturally safe. They don't understand or try to understand how Aboriginal people experience the system. There are big concerns around the high levels of cancer in the Mori community. There are no specialists in Mori, and again, it feels like this is not being addressed. In the end, poor treatment and the feeling their concerns aren't being heard makes people mistrust the health system. I do have some recent examples of how people were treated through the recent COVID outbreak, if the committee would like to hear about some of those.
Yes, just with this caveat that depending on the nature of the content, the appropriateness of de-identifying specific individuals in terms of using their names, yes. But please proceed. Yeah.
Thank you. Through COVID, access to medical services became even harder. Appointments with specialists who come up with the AMS were cancelled, including appointments for ear, nose and throat specialists, dentists, optometrists. It was also hard to get specialist medication through COVID. There were sometimes long waits to get COVID test results. People in Mori knew that in Sydney it can take sometimes only 8 hours to get tests, but some people in Mori had to wait many, many days to get their results. Some Aboriginal people in Mori thought they were treated differently and unfairly due to COVID. There were reports that the recent COVID outbreak in Mori started from a funeral in Mori. However, COVID was already present in the sewage system well before the funeral. As a result of the misinformation around that issue, some people in town were making discriminatory assumptions about anyone who was Aboriginal was at the funeral, and they were banned from entering shops. In one case, a person who put his car in for service was charged to clean his car on the assumption that he and his car was at COVID risk. Being unwell is stressful enough. Being treated with such contempt and unprofessional behaviour only makes this worse. So that will include my written statements from Just Reinvest and those collection of statements from the community.
Thank you very much.
Questions?
Thank you. Ms. Lloyd, are you, with respect to those two documents you've just read from, are you able to provide them to the Secretariat or email them into us to help us just accurately record what you've got?
Indeed, I will.
Just to enable us to double check. Well, thank you for that. And listen, with respect to the second part of what you said, could you pass on our thanks to Ms. Duncan, who obviously was involved in its preparation, and we acknowledge and thank her contribution. So I'll move to questions now.
Thank you.
Approximately 9 minutes or thereabouts for each grouping. So we'll start with the opposition, the Honourable Walt Secord.
Thank you, Mr. Chair, and thank you for your evidence and thank you for your time. I'd like to start off on your mention of no detox services and no drug and alcohol services. So if someone wants to seek treatment or assistance for drug addiction or alcohol, what would be the nearest service to the town of Mori?
So Mori, in fact, does have a small rehab centre in Mori. I think it has between 8 or 12 beds. However, to access that service, a person has to be detoxified first. So there is no admission without detox. There are no detox beds or centres in Mori, so people have to travel 3-4 hours away to either Tamworth or Armidale for detoxing.
So is there a waiting list, or is that not the way it works?
You mean for the rehab or for detox?
For both, actually. For both.
So the process is that someone can't get a rehab bed in Mori until they're detoxed. So there is a kind of confusing timing issue. One has to find themselves a bed in the detox and then transfer straight over to Mori for the rehab. So that is a logistical issue, but also it raises those issues that were raised earlier around transporting oneself down to one of those centres and then finding oneself back to Mori and hoping that there is a bed available at the rehab centre in Mori.
So as part of the response, we make recommendations to the government as part of a final report, and without putting words into your mouth, would you like to see one of the recommendations an expansion, or what would you like to see as a treatment facility in Mori?
I would refer the committee again to the special commission into ICE, which indeed sat in Mori, and one of the recommendations there, I believe, was for better access to drug and alcohol services in Mori. So yes, of course, we would like to see detox facilities in Mori. We would like to see more availability of beds. We'd also, in particular, like to see drug and alcohol treatment for young people, because that does not exist in Mori at all.
Now, you mentioned in your
people with,
Sorry about that. You mentioned in your opening statement that there was a 4-week wait to see a GP. Is that for Indigenous or non-Indigenous, or is that everyone in the Mori community?
My understanding is that is everybody in the Mori community, and sometimes it is well over 4 weeks.
Over 4 weeks. What is the availability of medical services in Mori? Is it a district hospital? Is it an MPS? What is the health facility in Mori itself?
There is a hospital in Mori. And I mentioned earlier, there is PIES, the Aboriginal Medical Service in Mori as well. But as the committee would appreciate, care is a continuum of care. So people may visit the Aboriginal Medical Service for day-to-day medical issues. In better times, there are visiting specialists on a sessional fly-in, fly-out basis. But there are times when some critical care will be needed, in which case people will have to visit the hospital.
Okay. Now,
District hospital.
It's a district hospital. Yeah. Okay, so would be like a D. Yeah. Okay, so it's a district. Yeah, district. Like one of my colleagues just said, it would be a district hospital. Yes. Now, you made mention to cancer treatment and that. Now, I know that we've received evidence across the state. How does treatment for oncology occur? Do you go to Tamworth or do you come to Sydney? I would assume there's no treatment locally.
My understanding is there is no treatment locally because there is no oncologist. There are no specialists, as far as I'm aware, in Mori whatsoever. So people would have to visit other larger places, like Tamworth or Armidale or Sydney.
Okay. And what's the population of Mori?
Google that.
So
approximately, yes.
Is around 8 or 9. Yeah, approximately 8 or 9,000, and the Aboriginal community there, I think at last census was around 2,800. That was in 2016.
Yeah. I've actually visited Mori, but I just wanted to get that as context for the. Now.
Yeah. So the LGA, the local government area, which includes some of the satellite towns, I think may bring it up a bit higher.
Now, if someone appears before a magistrate, and as part of the, are there any options for treatment as part of the sentence or rehabilitation? What happens in Mori in that regard?
So there is a local court, obviously, that sits in Mori. Many courts around New South Wales will have a justice health nurse that sits in the court, and that the magistrate can refer those people to for an assessment of their mental health. That facility there is no justice health nurse that sits in Mori local court. Other courts around New South Wales, as we mentioned, have the magistrate's early referral into treatment for drug and alcohol treatment. That exists in many courts around New South Wales. That does not exist in Mori. So the option. The mental health exact how those options are in. Sorry.
Ms. Lovick, we just lost you for about probably 4 or 5 seconds. Would you mind just circling back and covering what you said?
Certainly. Other courts around New South Wales have the MERIT program, the Magistrates Early Referral into Treatment program for people affected by drug and alcohol. That does not exist in Mori. Defendants before the court who may have mental health issues have access to diversions to seek seek mental health support. But those options are indeed very limited in Mori because of the absence of psychologists and the ability to make case plans that may support those diversions.
Okay. In your submission, you make mention of a phrase called postcode justice. Can you elaborate on that?
So I live in Sydney, and my postcode is very well heeled. I have access to any number of medical specialists. I have access to any number of lawyers. I have access to any variety of education I might choose from. In the case of justice and postcodes in Mori, that availability is disparate. Mm-hmm. So when we talk about postcode justice, we refer to the differential between access to support across a whole array of human services domains, which are not available in Mori, but compared to other postcodes are more available.
In other inquiries that have been held in the last 6 to 8 weeks on First Nation imprisonment, we heard evidence that female Indigenous population in New South Wales comprise about 1.7% of the population, but 35% of the female Indigenous imprisonment population. So 1.7%, 35% of the female imprisonment. Do you find similar evidence in the Mori region and the impact on the female Indigenous population? And could you comment on that?
Yeah, look, I don't have those statistics on hand about what's particularly happening in Mori, but we certainly do know that there is that terrible cycling in and out of prison in First Nations people, and that certainly has been on the rise in the last 10 years.
Okay, but how does...
Yeah,
sorry.
that is the case.
How does that impact on health outcomes for children and women and the community in general?
Well, I would suppose, what are the drivers into the criminal justice system in the first place, which is what justice investment is around, and it is around those untreated, that lead to people's interactions with the criminal justice system. So once again, untreated mental health issues, untreated alcohol issues, lack of access to appropriate housing, healthcare, are what see people come more in the face of the criminal justice system, combined with over-policing in particular places. That means people are more likely to, unfortunately, have a criminal justice response rather than a health response or a housing response. We have an issue in New South Wales that the first responders are often less because they are the 24-hour service. And I think police would agree that they would prefer not to be that first responder. The issue is we do not have the services either available or available at the right times when people need that assistance. And so the criminal justice system becomes a kind of stopgap. We'd like to change that. We'd like to see the resources shifted so that those underlying issues that see people drawn into the criminal justice system are better redressed, better funded, so that we don't have a criminal justice first response.
We now move to questions from the crossbench. Thank you, what's it called? The Honourable Emma Hurst, the Deputy Chair.
Thank you, Chair, and thank you for joining us this morning, and thank you so much for your detailed submission. You've highlighted that there are very high rates of suicide in Mori, and I think you said in your submission that it's not being addressed in a systemic and coordinated way. Obviously, this is extremely concerning. Can you give us an idea on what needs to change here, what needs to actually happen on the ground?
I think it's, as I said earlier, we need to have, in Mori, there needs to be appropriate, culturally safe mental health care. That needs to be available at all hours. That needs to be available to young people as well as older people. The service sector in Mori, and indeed in many regional places in New South Wales, is very siloed. There are, chronic gaps. There are duplications in places where you don't need it. So to address those issues around suicide, one needs to be looking at those underlying issues. And in the case of First Nations people, all those services need to be informed by culturally safe practices. People have a distrust of many of the mainstream systems that are well-founded, distrust of those systems. So there needs to be a rethinking of service delivery. It needs to be available 24/7, and it needs to be culturally safe so people will feel accessing those services.
Yeah, thank you. It's interesting because, I mean, obviously we're talking about sort of adding more services, but I also understand from your submission that there's been a psychologist position available for 3 years that you can't fill. Is that still the case? And can you give us an insight into, you know, what the struggle is to actually get recruitment into this space?
Thank you for the question. I think the statement around lack of access to a psychologist is from youth justice or juvenile.
Correct, yes, yeah.
That wasn't our psychologist. But the issue around, recruitment and retention of local professionals is an issue. It's an issue in Mori, it's an issue in many regional remote areas of New South Wales. People don't want to move to an outer regional remote location to be away from the services, education outcomes. So I think there is a genuine gap in professional services. This is not only health services, it's the same in the legal service sector, and sometimes I think the teaching and education sectors as well. So I think there is a problem. There have, I believe, been discussions around particular loadings and increased salaries to help attract and retain people into those regions. So yeah, I think that's an issue in terms of just recruitment.
Yeah, thank you. I just want to jump back as well. The Honourable Waltsecker was asking questions about the detox centre, and you were talking, giving quite a lot of detail about the fact that everyone has to travel to detox before they can enter rehab in Mori. Just if we can pull that apart a little bit further, just for the benefit of the committee. I know that, I've worked in the space of drug and alcohol previously, and there's so many hurdles to getting somebody into a detox centre anyway. But obviously having to travel creates more hurdles. Can I just get a bit of a feeling on the ground, what that means for people? Does it just simply mean that there's a huge number of people that are falling through the gaps because they don't have access to be able to travel outside of town and things like that?
Absolutely. The public transport systems between Mori and regional centres are difficult. They're expensive. They're not that frequent. People may not have access to cars. If people are unwell, they don't want to be driving somewhere as well. So there are just some very practical logistical problems with travelling. Leaving family, leaving your country, leaving your support network to go and detox only adds a further layer and a burden of stress on a person who's already clearly in a stressful situation. I do understand there are some government rebates available to travel, but through the Etiquette service, the awareness of that service is pretty low, and there are certainly restrictions in terms of accessing that. The kilometre allowance is lower than, for example, the ATO rebate on kilometre and mileage allowance. So, and being away from family, having to, if you're employed, having to leave your job while you go through that process, these collectively add up to a mindset that help. It all seems like too much. People will not do it.
Yeah, thank you.
Thank you very much. Kate Fairman.
Thank you, Chair. Thank you for appearing, Ms. Lawvick, and for the work that you do for Just Reinvest. I just wanted to, and firstly, thank you for raising the issue in your submission and your opening statement here today, which is a really, really important one around the links to health and justice. That hasn't really been a part of this committee inquiry before, and it's a really, really important perspective. I wanted to just ask whether, is there anything at a state level, any programs that the New South Wales government is doing to address or to support or help the situation of cognitive, as you say, cognitive disabilities and mental health disorders in young Aboriginal people entering the justice system? Is there anything there at a statewide level, like a program that is working or has been trialled, firstly?
I may have to take some of this on notice. I don't think there is any statewide program. There are discrete initiatives that may go to providing some kind of support. There is the Justice Advocacy Service, which is a service that assists witnesses, defendants, victims in their interactions with the police and in the courts who may have a intellectual disability or impairment, and they are there not as an advocate but really as a support person to ensure that those interactions are a bit safer, taking into account those people's abilities. So that service that does exist. But in terms of a statewide program that actually goes to address the underlying issues and treatment, I'm not aware of that. And you're right, we think this is a critical issue. People's journey into the criminal justice system is really because of those unaddressed underlying and untreated issues, and the risks put into the criminal justice spectrum of that journey are incredibly expensive and, of course, incredibly harmful. So we say that those resources at the end, at the criminal justice end, should be shifted towards those underlying issues, and the communities that we work with have very strong opinions on where they should be and how they should be placed.
Yeah, thank you. The statistics that you mentioned in your opening statement were just incredible. I think the 83%, I think something like that in the 80% compared to 13.9%. There was something there that was just alarming. So more broadly then, I suppose in terms of mental health treatment and support for young Aboriginal people across the state, are there programs there as well, or is that just done at a local level through the art shows and through mental health support work, Aboriginal mental health support workers kind of at the local level? Again, a question as to whether there are any good programs at a state level that we could look at.
I would probably want to take that on notice about whether there are any state programs. I'm not aware of those. I think you're right. There are a lot of perhaps ad hoc programs. There may be a government initiative or priority around a particular area and some very short-term funding that become available. There are a number of services in Mori that do really aim to get access to the funding to support those kind of programs, but regrettably they're never particularly long-term. And the kind of ongoing training and recruitment issues around filling those positions is definitely a challenge.
I did find it extraordinary, your evidence that there are no drug and alcohol services for young people in Mori. So that's young people full stop. That's not, I assume, not even just tailored towards Aboriginal young people.
Yeah, I mean, there is the space, which is as a Commonwealth initiative, and that's around mental health issues. But even with that service,
just
which
one follow-up,
drug and alcohol issue, it's very limited.
Okay.
So
Just one follow-up.
will not see people.
Sorry, no, we're talking to ourselves. If I've got time for one more question, I apologise. Continue.
So with Headspace, they will not address anyone in crisis situations, and the committee would be aware that there is a strong link between mental health and drug and alcohol use. And so people are excluded effectively from seeking help locally. So, I mean, our view is that there are, services around, they are well-intentioned, but not necessarily hitting the mark of what's needed and how they're needed to be delivered in a culturally safe way.
And can I just on that, just a question as to whether there has been any drug and alcohol services in the past in Mori, what the advocacy for that looks like, because you would think that alcohol and other drugs, alcohol and other drug providers or health workers there would have been advocating for this for some time. So what have the barriers been, do you know, for not getting something like that in place? Firstly, has there been any, and then what are the barriers to getting that in place?
There have been years and years of advocacy, and forests have been felled in the amount of inquiries that have been done around access to appropriate services in communities, including Mori, and I again refer the inquiry to the ICE mission.
Yep.
Those recommendations are still not implemented, but we believe there are some elements of that being implemented. These issues do remain open and unaddressed, and there is a lot of advocacy from the very wise people of Mori and their lived experience of these issues, but my understanding is there has been no implementation of any systemic approach. I do have to add that PIETS does have programs, and there's some amazing programs around social and emotional wellbeing, but it's that critical care issue which is missing.
Thank you.
Thank you very much. We now move to government questions.
I don't know if you could describe them as government questions, but anyway, we'll...
I withdraw that. Questions from members of the committee who are members of the government.
That's a safer way of putting it. Look, can I ask you this? You'd be aware that I have some knowledge of Mori. It seems to me, if you look historically at Mori, what you see, like many centres in rural and regional New South Wales, is that it's a community that actually is shrinking. It's losing services over a period of time. Have you been able to identify that?
Look, that's a really interesting case in point in Mori. As the committee may be aware, it is now the site of Inland Rail and the Special Activation Precinct infrastructure, which will in fact, under their estimates, see a significant growth in the population in Mori. There is talk around building up to 5,000 new houses in Mori to house people that are going to rush to Mori to build and service that infrastructure. So while there may be shrinking service delivery, there is anticipation of growth. And I think as the committee would be aware, that there is kind of resources of services happens in fits and starts. We often hear in Mori there are 72, 73 services in Mori. You know, $1 gazillion is being spent on services, but we're not seeing the outcomes one would expect. So it's an issue more not about the amount of the services, but about the quality, sustainability, and appropriateness of the services that are in town, and actually appropriately meet the crying need for support.
Fair enough. Well, let's look at the appropriateness. Yesterday we had some evidence given by the Far West Local Health District, and one of the inquiries that was made was how many Aboriginal people are employed, and particularly health workers are employed by that health district, and we couldn't get actually an answer. If you talk about culturally appropriate health services, do you agree that one of the elements of that is the need for governments to prioritise employing more Aboriginal people within those services?
I 100% agree with you on that one. It's no surprise that Aboriginal people will feel more comfortable accessing and receiving services from and that is absolutely the case. We do also understand that under the national Closing the Gap and state Closing the Gap agreements, that is one of the priority reform areas that Aboriginal community-controlled organisations who employ Aboriginal people are better resourced and are...
We've just lost you again.
So that sector, oh,
Just
okay.
briefly.
Can you hear me again now?
We can, yeah.
Yeah, right. What I was saying, and I'll just summarise, is that under the Closing the Gap priorities, one of the priority reform areas is to better resource and acknowledge and support the Aboriginal community controlled sector. And that will include Aboriginal community controlled health services. So that sector certainly warrants much more support because that's the services that First Nations people feel comfortable accessing because of the nature of service delivery, that trauma-informed service delivery mode, and people feeling comfortable in that environment.
But it has to extend beyond that, doesn't it? It has to extend into we'll call it the state-run health services as well. If you're turning up in accident and emergency, and I'll describe it as an all-white workforce, the sort of issues that you identify of distrust and perhaps a feeling of discrimination are almost an outcome of the whiteness of the environment.
Well, absolutely, and people in Mori do say that there are no First Nations people in Mori, and we do know that people will feel safer and more trustful if there are people like them helping them with the service delivery. You would be aware of the statistics around people discharging against medical advice, which are far higher in First Nations people than in the general population. And that is around people feeling 100% feeling culturally unsafe and not cared for within that mainstream service. So while we do need to support the Aboriginal community control sector, cultural safety needs to be implemented across the whole spectrum of mainstream services as well, especially in a place like Mori, where there is a significant proportion of the population are First Nations.
Sure. Look, I think the final area, and then I'll hand back to my colleagues, goes back to this issue of drug and alcohol services. I'd suggest that you would have seen, not only in Mori, but in many other of these smaller centres, I might get myself into trouble for that, but in these smaller centres, cases that are being adjourned again and again before the courts in order to get somebody into detox or into a rehab bed or centre, but even if they were able to travel, there aren't any beds in those other locations either. And eventually, in a sense, the magistrates sort of throw their hands up in the air of how long can we adjourn these matters for? That's not an uncommon experience that you would have seen, is it?
That is not uncommon, and I think you will find that people are united in throwing their hands up because of the lack of appropriate options available to them that would be available perhaps in inner Sydney and Parramatta. So we do see some amazing things like youth query court, and we see drug court, and indeed soon we have a version of the Wallama court starting up in Sydney as well. Those resources, regrettably, don't seem to find themselves across the mountains into regional remote areas where indeed we think there is greater need. That's not to say those services shouldn't exist or those mechanisms and courts shouldn't exist in the city, but we do need to see some equity in how these are spread out across, and that is, again, a matter of resourcing.
Well, I'm grateful for your evidence. I've run out of time, it would seem.
Yeah, well, that brings us to the conclusion of this session. So on behalf of the committee, thank you very much for making yourself available. I know you're very busy with a range of commitments, so appreciate carving out some time for us this morning. Been very helpful to have your oral evidence and testimony, which will augment what's been provided by the submission. So thank you once again.
Thanks to the inquiry for hearing from us and the people of Mori.
Thank you.
Thank you.
Well, we'll move then to our next group of witnesses shortly as we transition across. So just a couple of minutes transition. Don't go too far.
I won't.
That's fine.
Yeah, won't do. I've just got to go and give him some instructions.
Thank you.
Will do. When are you going? About 20 past? Oh, yeah. Yeah. I'll be back. Oh.
All right. Hang on.
Good morning.
Good morning, it's Andrew Rode here from the Secretariat. Ms. Rankin, can you hear me?
Yes, I can. Thank you, Andrew.
Thank you. Yes, I can hear. Ms. Thompson, can you hear me?
Yes, I can hear you. Can you hear me?
Excellent. Yes, I can hear you. Thank you. And Ms. Henry, can you? Ms. Henry's just stepped away. Ms. Henry, it's Andrew here from the Secretariat. Can you hear me?
Might be muted.
Excuse me, Ms. Henry, it's Andrew here from the Secretariat. Can you hear me?
To unmute.
Can you try unmuting your microphone, Ms. Henry, if you can hear me? We'll call you.
Thanks, Andrew. We'll just wait a moment till we can get a message through to Miss Henry. Can you hear us yet, Miss Henry?
Ms. Henry, can you hear us?
Andrew, we just sent her a text, did we? Oh, okay.
Oh, she's picking up the phone now.
Great.
She's picking up the phone now. There's this tiny,
Miss Henry, we got you?
second delay. Because I put my hand up to see, and then I watched, and it was
Oh, you could see it.
delay.
If you can unmute, please. Okay, so it's okay. That's fine. So we have a technical glitch, but we'll just wait another minute or two, see if we can overcome that.
Ms. Henry, can you hear us now? Ms. Henry, can you hear us now?
Yeah. So that'd be great. So I think on advice, we'll move Miss Henry back into the lobby and try and get the connection, which I'm sure we will. But in the meantime, we can swear in the other witnesses, and Miss Henry can join us shortly. How does that sound? Okay. So welcome to our witnesses for the next panel. As I described, we're just endeavouring to make contact with Miss Henry, but in the meantime, can I welcome Miss Rankin and Miss Thompson. Thank you very much for joining us this morning. Get through the formality of having you sworn or affirmed for your evidence. So I'll get you in the first instance to, starting with Miss Rankin, full name, position, title, and then swear either an oath or affirmation, whichever you prefer, the words of which should have been provided to you, but if for some reason you don't have them, just put your hand up and we'll provide them to you. So, Ms. Rankin.
Thank you, Chair. My name is Catherine Rankin. I am Policy Directors with New South Wales. I have responsibility for rural affairs and our business economics and trade portfolio. I choose this morning to take an oath. So therefore, I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you very much, Ms. Rankin. Moving now to Ms. Thompson.
Yes, my name is Sarah Thompson. I'm a member of the New South Wales Farmers Association. I'm also a committee member within that organisation on the Rural Affairs Policy Committee. I choose to say the affirmation.
Thank you.
I solemnly, sincerely, sorry, I'll start again. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me, truth, the whole truth, and nothing but the truth.
Thank you very much. Well, If it's okay, I know this is a shared session between yourselves and the Australian Lawyers Alliance, but we're still having a little bit of difficulty. But if we can proceed, and hopefully shortly Miss Henry can join us. Are you okay with that? If you're comfortable with that, we can get things underway and hopefully she'll join. If not, the time will just pass. But once again, on behalf of the committee, thank very much both of you joining, and thank very much the New South Wales Farmers Association, a very well known and well regarded organisation participating in this inquiry. Can I first of all acknowledge the submission that's been made to the inquiry by the organisation. It stands as submission 686 to the inquiry. A very thoughtful and detailed submission that's been received, processed, and stands as a submission to the inquiry and is available on the inquiry's webpage. What I'll do is invite an opening statement. I'm not sure whether this was to be provided by one of you or to be shared. How would you like to do that?
Chair, we have invited Sarah Thompson to make the opening statement on behalf of New South Wales Farmers. Thank you.
Thanks, Ms. Rankin. Please proceed, Ms. Thompson.
Firstly, good morning and thank you for the opportunity for us to speak to you today. Our role is one of advocacy on behalf of our farming membership, and our submission reflects the experience, issues and concerns with regards to health access and outcomes that they bring before us to raise in forums such as this. Health is complex and healthcare is complex. At its core are the people. We recognise an investment in health infrastructure has been committed to regional centres, and it builds capacity for more specialised service delivery in regional cities. However, it's the human capital that has the greatest impact on the delivery of health for us. The lived experience of our cohort is one of difficulty getting access to health care in a timely, location-based way. There's a strong value for the workforce we have. They have exceptional skills and dedication, but our communities are concerned for them. Believe that they are underfunded, under-resourced, overworked and fully stretched. The evidence supports our knowledge that people living in rural, regional and remote do not enjoy equitable access to health care, nor to health and wellbeing outcomes. Accessing primary care, dental care, allied health, specialist services is more difficult for rural people and requires greater time and expense. We do not have the answers, but we have anecdotal and lived experiences which we hope will contribute to your findings. We understand the distances that people are being asked to travel, the cost, the burden, the impacts both emotionally and financially that entails to access care. From the most basic presentation to emergency in a multiple where there is not a VMO, of driving 100 kilometres one way to attend emergency department at night, being turned away from a smaller hospital where a pregnant mother has been booked to birth because the time of the presentation comes when there's no theatre coverage and they're then transferred to tertiary centres, to being unable to access home care to help manage, keep our families at home, be it for aged care support, palliative care support, rehab recovery. We understand that there are significant challenges to find health professionals to work in the communities, especially in rural and remote settings. From backfill positions, maternity cover, to part-time, short-term for nurses, for allied health, to full-time general practice doctors. And we understand the challenges of distance. It seems that begging and borrowing from different sites provides short-term cover in one area while leaving another with a gap. However, the issues of access are not diminished over the course of time. In fact, many report nostalgically of localised healthcare models of the past. We have not got this right yet.
Thank you very much. And that's a very fine opening statement to open up our questioning. So we propose, if you're both agreeable, to... Oh, great. Miss Henry, can you hear us?
I can. I'm sorry about the...
No, that's not your fault. We always blame the telecommunication providers. That's what we always do. So, can I? So just we'll just pivot back to you. Can we deal with the formality of having you entered in to give your evidence? So can I ask you to provide your full name, your position title, and swear either an oath or affirmation, whichever you prefer, the words of which have been provided to you. If you don't have them, just put your hand up. So please proceed, Ms Henry. Yep. Okay.
My name is Catherine Henry, and I am the principal from Henry Lawyers, and I practice in Newcastle from the firm.
Mm-hmm.
I'm representing the Australian Lawyers Alliance today, and I elect to give an affirmation.
Thank you.
Solemnly, sincerely, and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thanks, Ms Henry. And just for the record, can I acknowledge and thank the Australian Lawyers Alliance for their submission. It's submission 694 to the inquiry, as I'm sure you're aware. It's been received, processed, and stands as a submission to the inquiry and been uploaded to the inquiry's website. So thank you for that. Can I invite you to make a brief opening statement, then we can open up the questioning from committee members. So over to you, Ms Henry.
Well, thank you very much for the opportunity to address this important inquiry today on behalf of the Australian Lawyers Alliance. We are a national alliance of lawyers, academics and other professionals dedicated to protecting and promoting justice and the rights of the individual. As you referred, we have produced a lengthy submission which I and other ALA colleagues prepared. Our members include barristers and solicitors whose practices include medical negligence litigation and who act for the many victims of medical and healthcare error in regional, rural and remote New South Wales and their families. In regard to my position, I have decades of experience as a medical negligence lawyer, practicing in Sydney for 15 years and for the last 20 years in Newcastle. My firm operates from the Hunter region, but we split clients from all across New South Wales. To our practices, we, the ALA lawyers and myself and the lawyers at my firm, we see firsthand the impact that inequitable health resourcing and other systemic issues have on those living in rural, regional and remote areas. These impacts are social, emotional and financial. You don't need me to repeat the statistics and research which show that people in regional, rural and remote New South Wales have less access to health services, have higher rates of potentially preventable hospitalisations and experience poorer health outcomes. A particular concern is the fact that people in regional and rural New South Wales don't have the same access to mental health services and timely mental ill health diagnosis as people in Sydney. And I have first-hand experience of that through a case I've been running in Mental Health Review Tribunal for the last month. I also don't need to repeat the client stories that were highlighted in our submission. The important point to take away from those stories is that people suffer avoidable death and significant injury because of preventable negligence caused by under-resourcing, lack of staff and systemic failures. We make 22 recommendations in our submission, but today I would like to emphasise 5 things to the inquiry. The first, our investment in health services is an opportunity to reduce the significant compensation payouts made by health services, health professionals and their insurers. Secondly, the need for greater and more transparent public data on adverse events causing serious injury and death. Staffing. We know and have known for some significant time that workforce shortages and lack of experienced practitioners is the major issue. 4, the importance of addressing Indigenous health outcomes and access to services and care. And 5, and I do know that this wasn't specifically mentioned as a term of reference, but I do note the need for the inquiry to look at reproductive health services and access as an issue in regional New South Wales. I'm not sure of the length of time that I have more points and I'm happy to talk further, but I don't know how much time is available.
Well, thank you. The submission is a very comprehensive one, and thank you for that. Listen, we would like to move to questions, but if what you say, Ms Henry, you've got another 2 or 3, 4 minutes, that's fine. But if it's going to go much longer, we'll start to carve into our questions. So how much you got left roughly, do you think? A few minutes?
I think 5 minutes.
What did the committee say, 5 minutes or? Okay.
Oh, yes, sorry. Yeah.
I think the consensus is please continue because it will be valuable. So, yeah.
Okay. So going back to the first point, medical negligence claims are costly. I've been doing this for 35 years, and I know, and I've seen the data, the data that is produced. You know, if you really, through FOI legislation, so it's not readily available by any means, investment in health services can reduce those costs. Sadly, legal action and the cost of compensation or the threat of legal action is often a catalyst for health services and health practitioners to change practices or invest in additional resources. The John Hunter Hospital and Maitland Hospital in the New England area are some of the most sued hospitals in the state. Information that I have accessed and that local journalists have accessed via different legislation reveals that negligence claims cost the New South Wales government self-insured Treasury managed fund and now Gallagher Bassett, tens of millions of dollars, hundreds of millions of dollars every year. There has been historically increased resistance to providing breakdowns according to specialty and practice area, and this goes to my next point on the lack of public data. We don't know the number of avoidable deaths and injury due to inequitable health resourcing, as access to meaningful data, including data by region, is unavailable. This is an area of responsibility for both state and national governments. Publicly available data helps make governments, health agencies and health providers more accountable. New South Wales and Australia is well behind other OECD countries regarding the collection and public display of health data. I know that in England and in the United States, adjusted death rates for a range of local hospitals can be obtained by the click of a button, by simply typing in the relevant postcode into a government website. Why can't we do that here? The New South Wales Bureau of Health Information that was established after the 2008 Garling inquiry produces a quarterly report on numbers of patients utilising hospital services and emergency departments waiting times, but not on numbers of adverse errors. AHPRA, the Australian Health Practitioner Registration Agency, does not provide remoteness analysis for the data it collects. This is a major shortcoming and must be changed. The AOA recommends agencies develop protocols to produce meaningful data as to adverse events. For example, data reporting on death certificates will predict due to adverse events or not reasonably expected outcome. Staffing, we all know that this is a key issue for access and this inquiry. It's a difficult issue to fix, clearly, but it's a crucial one. We need the development of a rural health workforce to be a national and state priority. The lack of permanent local practitioners has led to an over-reliance on locals. The system is less efficient and cost-effective than using local practitioners. It prevents patients from forming trusted relationships with a doctor or healthcare provider, which can cause a reluctance to attend for medical attention. Lack of continuity of care is also a risk management issue. The inquiry is correct in not just focusing on hospital staffing, but also the general shortage of GPs, specialists, allied health and primary care professionals. It means people in regional, rural and remote areas are waiting longer than those in Sydney to access care. The ALA supports the directions listed in the New South Wales Government New South Wales Rural Health Plan towards 2021. Enhance the rural health workforce by seeking to attract and retain a skilled workforce in rural areas. Strengthen rural health infrastructure, research and innovation by investing in regional capital infrastructure, implementing best practice models in rural settings to expand and support the delivery of high quality health services, and improve rural e-health solutions in rural New South Wales. There is little financial incentive to account for remoteness and increased responsibility of rural and remote healthcare providers. The General Practice Rural Incentive Program and the Practice Nurse Incentive Program are a start, but not indexed. Other incentives need to be examined. Work on the National Rural Generalist Training Pathway and plans for rural generalists to be recognised as a protected specialised field are examples of needed innovations. There could be opportunities to use paramedics as well as volunteer ambulance drivers in roles and settings where there is a dearth of other medical and health personnel. Students who undertake training in rural areas are 4 times more likely to decide to practice in rural areas, so we need to encourage more education and training, including rural rotations in training programs and degrees in regional, rural and remote areas. Indigenous health. On the issue of the continuing urgent need to address poor health outcomes and access to health services for First Nation people, the AOA supports and endorses the submission of the National Justice Project, and its submission deals very comprehensively with discrimination, which is unfortunately encountered. Another important point to make, and I made this point here in the address, but it wasn't addressed in our submission, is the need to look at reproductive health services. One example is access to abortion services. Abortion is the most therapeutic procedure in Australia, but women in regional, rural and remote New South Wales do not have appropriate access to these services. They are largely provided by NGOs. I do know that this week there's been an announcement about a pilot program being rolled out in Hunter, and I thank the efforts of local member Roseanne Sonia Hornery in her efforts on this area of health services. My final point is to implore each of you to ensure that this inquiry delivers recommendations that have been actioned. I was well entrenched as a medical practitioner. The Darling inquiry was held in 2008. I attended some of the public hearings that were held in the geographical area administered by Hunter, New England. The same issues that were discussed 13 years ago are still being discussed today. We need a properly funded database strategy to improve rural and regional healthcare. People in regional, rural and remote New South Wales are suffering. They suffer physically, mentally and financially because of failings to ensure equity in access and quality of healthcare. I'd be happy to answer any questions.
Thank you for that. We'll now move to questions, and we'll share the questions between the groups represented at the table. So we'll start with the opposition. Honourable Secord.
Thank you, Mr. Chair, and thank you for your submissions and your opening statements. Ms. Henry, you made reference to the difficulty in getting information about adverse events. Yesterday, we asked questions about Broken Hill Hospital, and it was very difficult to get information out of it. So how do you secure information on behalf of clients involving what the government calls adverse events?
Well, it's not something that I do as a matter of course. When it's not, it's in the policy work that I've been in my practice. I just know from the work that we do and the work, and we can see that the work that we do comes more often than not from rural and regional areas. When you're acting in a case, you don't need to know how many times this particular outcome has occurred. But when I've been involved in policy work, I took a plain substantial role in preparing the submission that is before you in this inquiry. And I have long been involved in the activities of the Australian Lawyers Alliance, and that's why it's very disheartening to have to make the same points year in, year out. I was, president of New South Wales, of the New South Wales branch of the ALA in 1995. So in 2001, the same points are being made. The access to information is not readily available as it is in the UK and the US. You have to search long and hard, make applications through GIGA and FOI to get the information that should be readily available. So we just have no idea. The government has no idea, other than anecdotally and through the media reports of this problem. At the extent of the problem, we have no idea. I do know, because I was also, I can hark back to the only study that has been done in Australia, and this goes back to 1995, is an inquiry which showed that 1% of those who suffer adverse outcomes actually do anything about it. There was a review. So in the US, they have done a study was done, which was reported in the British Medical Journal, that showed that iatrogenic injury was, adverse medical outcome was the third leading cause of death. A similar study was done in the UK. In 1995, the Quality in Health study that was done, commissioned by the then federal government, showed that we had an alarming rate of of adverse medical outcome, but the data is, it was called the Tito review, after the name of the woman, the bureaucrat who had the primary role, Fiona Tito, and that data is very old and was very hard to obtain.
So have you found that have you found that there's a disproportionate representation of adverse outcomes, preventable deaths in rural and regional areas?
Yes, I have.
Can you give me a bit of a context or a proportion or an illustration of that?
I can't because I don't. I can only refer to my experience, like the cases. I've worked in Sydney. I've worked in Newcastle. I've done this work for. I've been a medical. I've only done medical negligence litigation since 1989 when prior to that time I was at the Healthcare Complaints Commission. My experience is that the work has come in from regional New South Wales, from towns like Warriner and Canamble and North Coast New South Wales. When you leave Sydney and travel west or travel north or travel south, we don't have volume practices. We don't have numbers of doctors. We don't have doctors with specialised skills. So of course, the incidence of adverse outcomes will increase. But I guess I just can't. My point is that data doesn't exist, but needs to exist. And it was a recommendation of the Garmin report back in 2008, and hasn't changed.
Thank you. And now thank you very much. I'd like to speak to Ms. Sarah Thompson. Ms. Thompson, now you've made public statements about your consideration of an overemphasis on health infrastructure rather than staff. You'd be familiar with a number of areas in New South Wales where there are what are called ghost wards, where there are operating theatres and hospital beds where there are no medical staff in those, and the government's unable to provide health services to patients who want to be there. So in fact, they're empty. Have you heard similar stories?
Yes, I have heard similar stories. I guess one of the current ones that pertains to our area is the visiting medical officers that are not available at the hospitals for surgical cover or things like that. For example, a birthing mother may have pre-booked to birth at one of the local smaller hospitals, and the presentation might occur on the weekend, but because there's no theatre coverage, she's then moved to a tertiary for that to take place. I'm aware of beds being available in multi-purpose services in rural areas where if you've got pneumonia or you've got an acute illness, you're unable to be admitted because there's no VMO coverage into that. I have also anecdotally stories from all around. We hear the stories all the time, but they're just sort of two specific examples that I can give you.
Now, can I ask you for a comment on this? Now, it's been put to me that poor health services in rural and regional areas are actually discouraging young people from looking at farming as a vocation. Have you received feedback to that effect?
I think that I think that if someone's going to go into farming, that normally requires a passion beyond service availability of connectivity or health provision or education. I think the difficulty we see constantly is the ability to attract workforce or attract human capital to the communities that serve our farming businesses. And so, yes, and I also know that many people with young families that might be considering coming. They're the three key things that will cause them to sort of do some more research. And our ageing population very frequently will withdraw from our smaller rural and remote communities because they fear that their health needs will not be met in them.
So just with the adults, I'll rephrase my question and it'll be very quick. So because of poor health and hospitals, medical services in rural and regional areas, would you agree that it makes it more difficult to attract labor and workforce to farms?
Yes.
Yes. Okay, thank you.
Thank you. We'll move now to the crossbench and the Deputy Chair, Emma Hurst.
Thank you. Thank you, Chair. Ms. Henry, we've talked a little bit in your opening statement and in your submission as well, that Australia is falling well behind other countries in regards to the collection and publication of health data, particularly death rates in hospitals. I'm just wondering if you're able to point the committee to other countries that do have a better system for collecting and publishing data.
You can learn a lot from the way it's done in the UK.
Mm-hmm.
I do note I often look at the way in which the type of law that I practice is practiced in the UK, and they have a much more developed community system, community sector than I think than we do, and the information there is, so I think I would draw you to the work that's done by a national charitable organisation called Action for Victims of Medical Accidents, which is a very useful resource, great website, do a lot of very good work, very good policy work, and the UK is I think we could learn a lot from the way in which they manage their health data and emulate a similar system in this country.
Thank you. Your submission also highlighted the over-reliance on temporary locums to fill gaps in rural areas. And you say that a lack of continuity of care can be a risk management issue. As lawyers that are working on medical neglect cases, is this something that you see often, that it's actually that lack of continuity of care that's actually leading to some of those adverse outcomes?
That's just but one reason. What I can say is almost exclusively the cause of the reason for medical negligence litigation is the high incidence of systemic issues in our public hospitals in particular. Most of the work that my peers and the law, my work done at my firm is litigation against publicly funded hospitals where staffing is not as it should be, where communication is not as it should be, where junior doctors are not supervised properly. So almost every case that I've ever seen has involving avoidable medical accident has arisen from a systemic issue of some type or
Thank you. Just moving on, I've got one question for Ms. Rankin. One of the recommendations that you made in your submission is that an audit of medical equipment available in remote areas be conducted to determine gaps and enable appropriate resource allocation to increase locally delivered health interventions and preventative services. Can you talk a little bit more about this recommendation and what kind of equipment you're concerned is lacking in remote areas? Or can you give any examples?
Certainly, I will make an attempt to. Our concern is that often the leading edge technology and resources tend to be placed within high population density areas such as metropolitan. Still, we find that the technology, the equipment in regional areas is tended to be lowly prioritised in terms of replacement and care. So we feel that, and without having specific data, we feel that an audit of what's available in regional hospitals to either confirm or debunk that assumption is really important. And then that would also then lead to a better identification of how resourcing for the purchase, maintenance, and improvement for those materials could be made available. Thank you.
Thank you, Chair. I'll just, I think, go to the New South Wales farmers representatives firstly with this, and maybe Ms. Henry as well. Just, this is a question around health promotion and disease prevention. All throughout the inquiry, of course, we've heard of the greater health inequities in regional New South Wales. What more could be done in regional and rural and remote New South Wales, specifically in the area of health promotion and disease prevention?
I think maybe that question, disease.
I can't see who's speaking.
It's not something I'm not a.
You may take it on notice if you wish.
Yes, I might take it on notice. It's not like health promotion. I know that
It was actually to the farmers rep.
It's not my area of expertise.
That's okay. Sorry, just to jump in. Is any from New South Wales farmers? Is there Ms. Thompson or Ms. Rankin? I think it was in. You did have something in relation to this in your submission, Ms. Rankin. Is that something you cared to address?
Yes, I'm happy for Ms. Thompson to respond to that. But I'll make the first comment, and that is that farmers tend to be more remote, even though they live in remote or regional settings. They tend to be a little bit isolated, and they tend to trust peer-to-peer information. So anything that helps to equip farmers to talk to their peers, to talk to their families about these issues is really important. So anything in a clear, plain English setting is really important. But Sarah, you might like to add some more.
I think that the communication cohort, as Kathy said, is something that works with well. If we look at things like what services are available in, for example, community health, where do you go to get access about that? Finding that accurately presented on websites, I think, is problematic. Being involved in palliative care as a consumer and previously a clinician, you go to Cancer Council, for example, and there's a whole heap of pamphlets that say what's available and what procedures and what you can get from where. And that's not readily available in communities for people, so to be able to find out. There's also in public communities, when you're going into public places, it's quite good to have brochures that you can pick up and read what's available in your local community health centres. And I think that that's also perhaps not widely available. There's a program at the moment that is called, it's a peer support program, and it's called FarmGate. And it's meant to be able to, what it does, support low-level mental health early intervention. And that model of care works really well as it provides someone with lived experience to give a gateway to conversation. It overcomes the cultural barriers. But how do people know that it's not there? And how do they know who to contact? And at the moment, it's the clinician that's working in our region is actually just, she's the one that's doing the research, saying, oh, here's a group, maybe can I come and talk to you? Well, here, we've just had floods. She's the one that's driven out to the community, then talk to the community here that says, what can I do, where can I go? But that isn't coming from anyone else other than her. How do you know it's there? Farmers will also access health information through their context through the LLS. Are there brochures of the LLS? I talk to brochures a lot, because often it's that incidental pick-up of information that provides some insight into what's there. I don't think that the promotion of health services is well publicised. I would think that as a clinician, I put my clinical hat on to publicise the service that I offer, which would then bring, or that I did offer because I'm retired, that would then bring more people into that service, creates a stress point that is not met because there is not the staff to do that. You can list of what the palliative care services are in the community that I live in, for example. There are two full-time equivalent palliative care nurses to cover 11.5.
We just
lost her at the number.
just sorry to interrupt. We just a break in transmission about 3 or 4 seconds on the numbers. Could you please just return back and repeat those again? Sorry.
Was that regarding the palliative care?
The number,
numbers I was
Yes,
talking about?
the numbers. Yes, thank you. Yeah, we just missed that. Yeah.
Okay. So speaking personally, 2 full-time equivalent palliative care nurses, providing clinical support in cover the Upper Hunter Shire and the Muswellbrook Shire, which is 11.5 square kilometres. So therefore, there's no after hours and there's no weekend coverage because that's impossible to manage. So you publicise what palliative care support is, you put it out there, but maybe you can't meet the expectations of the community because you don't have the staffing numbers to do that. I mean, you would need 3 full-time equivalents to be able to cover after hours or weekend work.
Understood,
so
thanks. Yeah.
Promotion of health, I'm just trying to say there's a conundrum there.
Yes, no, it's
as well.
appreciated. Yeah, thank you.
Can I just step in and just say that, draw the committee's attention and just talking about, continuing on from what Sarah has just said about access to brochures, access to information, that there was a particularly good resource available to those in regional New South Wales, an initiative of the New South Wales Department of Primary Industries, which used to produce, but it had a very good website, used to produce really good material, a hard copy publication that went out to women, admittedly, so half the population, called the Country Web, and because of lack of funding, I don't know whether either Kathy or Sarah know about the existence of this good resource, but it was an excellent resource, specifically for women living in regional and rural New South Wales, and a source of information to me as a health lawyer about what was of interest and current concern. So yes, I think there is always there are lots of opportunities for communication within networks, community networks.
Okay. Do you have a follow-up?
That's fine.
I've got a question on a different matter. Okay, thank you. A question, just my last question specifically for Ms. Henry. You have the recommendations in the excellent submission you pulled together, so thank you for that. Recommendation number 22. I just wanted to get you to expand on this if you could, which is the amendment to the Mental Health Act to permit suitable remote facilities to operate safe assessment rooms for mental health patients on the basis that 3-hourly reviews of patients be undertaken by a senior nurse or psychiatrist over video link. Could you expand upon the need for that? If
yes, I mentioned in my opening statement that I've been involved in a case which has come before the Mental Health Review Tribunal on 3 occasions during the course of a month, which is highly unusual. And that it's apparent to me through the mental health advocacy work that I've done, and also having been a legal member of the Mental Health Review Tribunal, that the resourcing of mental health services in regional New South Wales, and I'm talking here exclusively about the Hunter, is far from what it should be. And we have had, and I have been contacted by people at the ABC who refer to the fact that the Hunter New England has a disproportionate number of adverse outcomes in the mental health setting. There was a much publicised decision, a case of a tragic suicide of a young woman called Alia Raftery, who there was an inquest concerning the circumstances of her death, and then subsequent disciplinary proceedings, as a result of which the nursing staff were, two of them were taken off the register. One was received some sort of disciplinary sanctions. I think it was a reprimand. Anyway, the point was that the surveillance of the staffing is such in mental health facilities that those who would need to be on 15-minute OBS, half-hour OBS, 1-hour OBS, often don't get those opportunities because the staff are just run off their feet. That was the circumstances that led to this tragic death of Ali Rafter. Was just one that received publicity through the inquest process, but there are others. It's come to the attention of those who report on cases and look at this area of practice that widens at the Hunter New England, the Breslin decision, the McKenna decision. We don't see involuntary patients. That's not the way. There is a lack of resourcing for advocacy of those patients.
Miss
Psychiatrists, we need better surveillance, and it's an area that needs reform.
Thank you, Ms. Henry. Ms. Henry, I'd like to jump in on the last question. I think you got about a minute. You mentioned in your opening statement that it was tens of millions of dollars, and then you changed it to hundreds of millions of dollars the state government pays in medical negligence cases. How are these settlements and these figures reached, and how does that, I guess I'd like to get how it actually occurs, a settlement, the amounts paid, how does that actually work?
Well, there's a system for assessing the monetary value of a claim that's well entrenched, and a case that I've just recently been involved in resolving, involving the avoidable onset of bacterial meningitis.
Oh, yes.
And I referred to that case in the submission, so I guess it's within the last 12 months. Her case was, that particular case generated a settlement of in excess of, and I'm not able to say too much, but north of $10 million. There was you want to look at the way in which these cases are quantified and particularised, and how we get to the end result and how the damages are calculated. I'd refer you to a decision, a medical negligence case against an obstetrician, Diamond, and the plaintiff's name in that case is very few. In fact, hardly any of these cases are reported publicly in the case reports, because we have developed to a culture of mediation. So a lot of these cases resolve behind, in fact, almost all cases now are resolved behind closed doors. But Calandre Simpson's case, which is in the public domain, resulted in a verdict of $14 million. So it doesn't take many cases to, when you a person who has received catastrophic injuries, as my meningitis client did. She had some very mild developmental issues before she received this substandard care. Now she's unable to walk, talk, and be educated, and requires 24-hour care. So that's why these results, some of the cases that I referred to in the submission, have.
And you
will never compensate the person for the loss of their life, or effectively their loss of their life when they've been the victim of catastrophic injury. But it's the system we have, and the cases often result in outcomes not often, but can result in multi-million-dollar verdicts.
Now, you mentioned that the Hunter New England local health district had a disproportionate number of negligence cases involving mental health. Is that still the case?
Correct.
Is that still the case in that local health district?
Yes, I was approached a journalist from the Radio National program Background Briefing, who producer have come to their attention that Hunter New England had a disproportionate number. As I said at the early part of my presentation, when you're at the coalface running these cases, one by one on an individual basis, you don't, you might make the observation, gee, that's the sixth case involved for mental health services that we've run this year. But you're not actually, because again, we don't have the stats and the cases are resolving behind closed doors as a result of mediations or settlement conferences. We don't know. There's not that sort of interaction and provision of information that allows you to discern trends. But yes, it is. It has been talked about. I can say that it has been talked about within the medical legal fraternity. I think the fact that the ABC are onto it as a story that is deserving of investigative journalism, which is what that program does, indicates that it is a problem. And the publicised cases, the ones that have all, look at the last 10 years of mental negligence cases that arose in psychiatric facilities that have all, I think, involved hunting.
No, that's just...
Thanks. Sorry.
Thank you.
Look, can I just thank New South Wales farmers for the quality of their submission?
Yes.
It will be very useful to the committee. Yeah. I don't need to ask any questions.
Yep. Thank you. Yeah.
Can I concur with the Honourable Trevor Khan,
Yes.
Deputy President, that the evidence from both the Australian Law Alliance and the New South Wales Farmers Association has been very high quality today, and has left us much to reflect on. So, on behalf of the committee, thank both organisations very much. This material, obviously, as you know, stands as oral testimony, evidence to inquiry, which will augment very nicely the detailed content of your submission. So thank you very much. It will certainly be important in informing us in terms of the deliberations over our report and recommendations. So once again, on behalf of the committee, thank you both very much. Thank you. Okay, we'll transition to the next set of witnesses.
How much time do we have? Do we have time for...
Yep.
Okay.
Yep, I know what you mean.
You have time? Yeah.
We have time.
I think you struggle to... you can turn Ms Henry's evidence into any credible story.
Yeah, she's quite impressive.
Hello, this is Maren Thompson from the Secretariat. Can I just check, Dr. Johnson, that you can hear me, please?
Dearie me.
Yes, I can.
Thanks, Dr. Johnson. Ms Maloney, can I check that you can hear me, please?
So do you know when next year,
Yes,
or
I
do you just
can,
go into a
thank you.
rolling list now and wait?
Ms Evans, can you hear me, please?
I can hear you, thank you.
Thank you.
Oh, it's
And
sometimes-
Mr Stevens, can you hear
It's
me?
true, but sometimes it is very difficult to finally get your client to...
Great. Thank you very much for joining us. The committee is just taking a few moments break and we'll be with you shortly.
Thank you all very much. Won't be long. Thank you. Thanks, Maren.
In days past, registrars used to offer parties go. Not let parties go until it's done.
Just while we're waiting for two committee members to return who will be doing so shortly, we can get through the formalities of the swearing and the affirming of you in, which is what we need to do before we can commence questioning. So is that okay? We'll do that first. That's what we need to complete. So on behalf of the committee, can I thank you all very much for making time available. We know you've got very pressing demands and very busy, and appreciate carving out the time you have done so to make yourselves available this morning. So we'll deal with the swearing and the affirming in, and that will require just moving through the four of you. to state your full name, your position title of the organisation you're representing, and then swear either an oath or an affirmation, whichever you prefer, the words of which should have been provided to you. If not, just raise your hand and we'll provide that to you. So that's the formality. So I've got just a list of names in front of me, the four of you, so I'll just go down that list in that order. That might be the easiest way to deal with it, and then we can move on with the opening statement. So commencing with Dr. Johnson. I ask you please to.
Yes, I don't have the alphabet, but my name is Johnson.
Okay, no, we'll get the words. Sorry.
I'm President of Services for Australian Rural and Remote Allied Health.
Okay, we'll just get the words for you for the affirmation. So if you repeat after me, please, Dr. Johnson. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given
I think he's got.
by me shall be the truth,
By me shall be the truth,
the whole truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Thank you very much. So we'll move now to Ms. Maloney.
Thank you. My name is Catherine Maloney. I'm the Chief Executive Officer of Services for Australian Rural and Remote Allied Health.
Thank you.
And I have the affirmation here in front of me.
Thank you.
I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. Moving on to Ms. Evans.
Thank you. My name is Leanne Evans. I'm the Senior Policy and Relations Advisor for Exercise and Sports Science Australia, and I have the affirmation in front of me.
Thank you.
I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you. And Mr. Stevens.
Thank you. I'm John Stevens. I'm the most recent co-chair of Exercise and Sports Science Australia New South Wales chapter and have the affirmation. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thanks, Mr. Stevens. Well, once again, thank you and welcome to you all. Can I just acknowledge before we commence and thank also both organisations for the making of submissions to the inquiry with respect to Services for Australian Rural and Remote Health Allied. Excuse me, start again. Services for Australian Rural and Remote Allied Health. Your submission's been received. It's submission 473 to the inquiry. It's been processed and now stands as a submission to the inquiry and has been uploaded onto the inquiry's webpage. And with respect to Exercise and Sports Science Australia, equally, thank you for your submission. It's been received, processed, and stands as submission to the inquiry, submission 456, and it's also been uploaded onto the inquiry's webpage. Can I invite opening statements now from both organisations? Conventionally, it's normally one person does the opening statement for each organisation. If there's a reason to depart from that, just let us know and we can sort of deal with that. But if we start, first of all, with Services for Australian Rural and Remote Allied Health, who would like to make the opening statement or who's been delegated to do so?
I've been delegated. Thank you, Chair.
Thanks, Ms. Munn.
We did. So we'll proceed. We were planning this to be after S's statement, but that's fine. It will still work the same. So.
Is that okay? Because I mean we're flexible. but the opening statement normally sets up the questioning, so...
It will be fine. It will work fine.
Okay, go ahead.
Okay, so I acknowledge the traditional custodians of Ngunnawal and Ngambri people from whose lands I'm speaking on today, and those of the Wiradjuri people on whose lands my colleague Ed Johnson joins the meeting. I also acknowledge the traditional custodians of the land, seas and waters throughout Australia and pay my respects to elders past, present and future. Thank you for inviting us to contribute to this important inquiry. I'm Catherine Maloney, CEO of Services for Australian Rural and Remote Allied Health, or SARA. I'm a physiotherapist by background and have worked in both public and private sectors as a Director Allied Health and Senior Allied Health Manager in rural New South Wales Local Health District, served as a member of a New South Wales Rural Primary Health Network Board, managed a remote Aboriginal community controlled health organisation but not in New South Wales, and held other service roles. I'm joined by Ed Johnson, President of SARA, a speech pathologist who lives in Blaney and has extensive experience practising across New South Wales. Ed has been a member of the Clinical Council at the Western New South Wales Primary Health Network, has a PhD researching online therapy in rural and remote settings, and lectures for the School of Health Sciences at Western Sydney University. We both have extensive clinical experience working in and with the New South Wales health system. SARA is a peak body representing rural and remote allied health professionals. Our members live and work across regional, rural and remote Australia in public, private and community sectors, health, aged care, disability and other settings. Our New South Wales membership includes at least 16 distinct health professions. We are informed by the breadth of our members' experience within and across service systems. Our submission focuses on allied health. We acknowledge the vital roles of our nursing and medical colleagues, but note the relative lack of allied health workforce and service capacity, especially in rural and remote New South Wales, is a major systemic shortfall that contributes to the poor health outcomes experienced by people living in rural and remote New South Wales. We understand the inquiry is primarily about New South Wales public health services, but allied health workforce and service systems frequently span other settings, primarily health, aged and disability services. Where access to allied health services are lacking and puts extra demand on public health resources, resulting in higher avoidable hospitalisations and readmission rates, for example. As a result, where few allied health services are provided through the Commonwealth MBS in rural and remote New South Wales, when NDIS participants can't access allied health services and NDIS funding goes unspent, and when older Australians miss out on home care services to keep them well and independent, it all has an impact and the consequences are often felt at the local hospital. But even within the local health district, the allied health workforce and capacity to deliver these services is often not available, unsupported or overstretched. Yet having access to allied health services will address the health needs of rural communities where we see higher rates of chronic disease, an older population, lower incomes on average and higher rates of preventable hospitalisations. Operational management, reporting structures and clinical governance within rural hospital services need to facilitate increased involvement by allied health in order to improve access to services that will help people to manage their own health and prevent unnecessary hospitalisations. We need to see a greater number of allied health professionals filling operational management positions with responsibility for allied health service delivery and developing innovative integrated models of care. The practice of not budgeting for backfill of allied health positions needs to stop, as this has a direct impact on service continuity and in some cases has led to loss of substantive positions over time. Greater flexibility is needed to enable multidisciplinary and cross-sector models of care that make use of the available workforce capacity in rural communities. The extreme short supply of these resources mean that they must be drawn on wherever they are available. There are successful examples of public-private partnerships, such as operate now in the Murrumbidgee Local Health District, providing allied health services to hospital inpatients, aged care recipients and outpatients in rural regional townships. SARA would be happy to help embed more of these innovative service models. Thank you.
Thank you very much, Ms Maloney. Moving on now to Exercise and Sports Science Australia. Who would like to make the opening statement?
That's me. Thank you, Chair.
Thank you very much.
I acknowledge the traditional custodians of the land, seas and waters throughout Australia, especially the Yugambeh language people where I'm speaking to you from today, and pay my respects to elders past, present and future. My colleague Leanne Stevens is speaking to you from the lands of the Biripi people. I also acknowledge any Aboriginal and Torres Strait Islander people who might be involved in the inquiry and or listening today.
Thank you.
And thank you for the opportunity to speak to you today. My name is Leanne Evans and I work for ESSA in Government Relations and Policy. ESSA is the peak professional and accrediting body for accredited exercise physiologists who use exercise therapy to treat people with chronic conditions and injuries, and for exercise scientists who often work as allied health assistants and in the NDIS. John is an accredited exercise physiologist and business owner with 7 rural and regional clinics. Treatments that AEPs deliver offer good value for money, especially in regard to type 2 diabetes, with an estimated health system saving of just over $5,000 per person per year. AEPs can help patients reverse and manage diabetes through improving blood glucose levels. AEPs can also help prevent hospital admissions and readmissions. Despite allied health comprising the second largest clinical workforce after nursing and midwifery, it is often the forgotten grouping in healthcare. As a small and newer self-regulated health profession, there is limited consumer and professional awareness of exercise physiologists' roles. Reporting structures and clinical governance of AEPs and allied health staff needs to be improved. Not all staff are operationally and professionally managed by allied health staff. Many are managed by nurse unit managers, but no allied health staff manage nurses. There are not always positions for allied health professionals on local clinical councils. When allied health staff go on annual leave, their positions are not automatically backfilled like nurses' positions are. Exercise physiology services mostly cease when AEPs take annual leave. There are no AEPs recruited in most local health district casual pools to help fill vacancies. As of June 2019, there are almost 60% more AEPs working in the Victorian public system compared to New South Wales. In New South Wales, exercise physiologists are more widely employed in inpatient cardiac rehab, mainly in larger urban locations. Changing workforce practices and introducing more efficient and effective multidisciplinary models would see more AEPs in teams in mental health, cancer, renal and diabetes units, and in reconditioning hospital patients and older people in the community. Public-private partnerships could be strengthened with an exemption from the sessional contracting rates in rural areas with big gaps in service delivery. We encourage fewer short-term contracts and project funding and more permanent roles. Many AEPs are employed in lower graded positions or not working to their full scope or direct scopes of practice. Greater flexibility for reallocating budgets and making some roles physical therapy roles across exercise physiology, occupational therapy and physiotherapy would better support clinical needs. We ask that you support our campaign to remove GST from exercise physiology and talk to the federal government about extending the workforce incentive program to allow allied health businesses to employ allied health staff supported by subsidies currently only available for general practices. 2 New South Wales health staff, Nicola Clemens and Andrew Davison, need to be congratulated for their work in New South Wales becoming the first and only state to allow allied health professionals, including exercise physiologists, to administer COVID-19 vaccines in state-run clinics. Thank you.
Thank you very much, Ms Evans. Just for the purposes of the record for Hansard, the acronym AEP, can you just give us a long form of that so we've got the accurate record?
The acronym AEP stands for Accredited Exercise Physiologist.
It was, so.
And we'll be happy to email in our opening statement to Chair.
That would be most helpful, so thank you for that. We'll move now to questioning from the groups around the table, opposition, crossbench government. So starting with the opposition, Honourable Secord.
Thank you, Mr. Chair, and thank you for your opening statements. Dr. Johnson, now, you said that you were I just want to make sure I get this correctly. You indicated that you're a speech therapist. Is that correct? Okay, thank you. What is your and your practices in Blaney? Is that correct?
My practice is based online, so we service people across Australia. I'm physically based in Blaney, and I see clients and patients across the central west of New South Wales.
What is the wait to see, if you wanted to book an appointment today, when would someone be able to get into your practice or get online or get your services?
We're a relatively new practice, so it's significantly shorter for us. It's only a couple of months for us, but...
That's short. I'm sorry. Everything is context.
Yeah.
There was a response here when you said a short time, 2 months. So, what is a long time to wait for?
Generally, the average wait time is 18 months to 2 years, and that includes for early intervention. So kids who are referred to speech pathology through general practice, through the NDIS, through any means, at kind of preschool age, we're still looking at 18 months to 2 years for the vast majority of speech therapy services.
So, okay, it's been a long time since I've studied education in child development, and it's been 30 years since I've had a small child. But isn't 2 years a long time in the development of a child if a child has speech problems, autism, things in that area?
It's an incredibly long time. If we're not getting to kids before they're 5 years old, a lot of the issues that they have are incredibly difficult to remediate, incredibly difficult to teach them new skills. So those kids are already behind by the time they get to school. And in terms of speech pathology, you're having trouble then with reading, socialising. That has kick-ons in terms of being able to engage socially in class, being able to pay attention in class. And what we're seeing when those kids get older, because of those long waiting lists, that those kids are disengaging even as early as mid-primary school. They're not attending school. They're getting involved in the criminal justice system. There are mental health implications as well. And a lot of those kids, unfortunately, are kids who are ending up in jail. And the amount of people who, and young people especially, who end up in the criminal justice system are people with speech and language disorders which could have been prevented.
Now, are there certain parts of New South Wales, certain parts of the state where there are no allied health workers, particularly speech therapists, available at all?
Yes, to my knowledge, particularly in northwest New South Wales, the problem is particularly bad, especially around towns like Burke, Brewarrina, Walgett. There are minimal visiting services, but there aren't community health services, and there's a huge gap between someone who's accepted into the NDIS and kids who have hearing difficulties, kids who have speech and language and developmental concerns that won't qualify for NDIS, and they currently can't be seen by public health services. Even if they are, it's usually a matter of 6 half-an-hour visits and then a break from therapy for quite some time. And I think if I can put that into a meaningful context, again, to have a therapist see you 6 times for half an hour, if you go to 6 half-an-hour piano lessons, you're not going to come out playing like Beethoven. You're going to have a very difficult time even getting up the scales. So that is the offering in many community health settings at the moment, if there is one. There isn't in towns like Brewarrina. So it's often a sort of lip service almost, and families are left disengaged then because they don't see progress, they don't see continued support. So if they're offered assistance a second time, they often decline because they don't see it as being in any way meaningful or effective.
Okay, but this is just not limited to speech therapy. Would you have provide similar evidence to, I guess, podiatry? Maybe nutrition, things like that. But you're the association, yeah.
I couldn't speak specifically to podiatry, although there are very similar waivers for occupational therapy, and that's almost the same situation as we're seeing for speech pathology. Kath may have particular thoughts on other disciplines.
Okay, could I get a snapshot from her, please? She's on mute.
Could you please unmute? Or
Sorry, my apologies. I have here workforce data for New South Wales on podiatry and a range of other disciplines. So in terms of workforce distribution, there is a substantial drop-off in the numbers of podiatrists available once you leave Modified Monash Zone 3, which are your large to medium-sized townships. And so those that are present in Modified Monash 5 zones is around 2% of the entire workforce, and podiatry is not a large workforce, so you're probably talking about a handful of podiatrists there, and the numbers drop off again to 0.2% in Modified Monash 6 and 7 zones.
Yeah. I was wondering Sorry, I was just wondering if you could you identify some of the towns in those areas so we don't know the jurisdictions you're referring to by that description.
I don't have this data by township, but you'd be talking about places like Houston, Ivanhoe, further west. So very, very small townships. The implication being that lack of access to podiatry services has a direct impact on amputation rates. So if where you have a high prevalence of diabetes, for example, and high risk feet, the lack of podiatry services means that these people cannot be managed effectively in the community, which leads to a higher rate of amputation.
Okay, so we make recommendations to the government as part of our findings. So what would you like to see occur or recommended to increase access or facilitate more allied health workers in rural and regional areas?
There's no quick fix to this, but and to an extent the state governments have done some work towards workforce development, and in New South Wales notably the work to improve the numbers of allied health assistants. But that in itself is insufficient. There are very few controls in place to support allied health workforce development at pretty much every stage of the workforce development pipeline. So we would like to see, for example, quotas for students from a rural background entering into the allied health professions to study, because the evidence tells us that if you're from a rural background to begin with, come back and practice in rural and remote areas after graduation. We also need to see further development of the pathways into the professions. So I've mentioned allied health assistants. While this is an important career in itself, and often is a fantastic opportunity for growth in jobs in regional areas, it is also an important pathway into the profession, so that if you've got somebody who's got a background at working as an allied health assistant already, these potential workers have great potential to become allied health professionals in the future, as long as there are flexible delivery options, flexible education offerings for them, so that they don't have to leave home to study. So, which leads to my third point, which is about flexible delivery options by universities to ensure that people don't have to leave rural communities for a substantial period of time to obtain their degree. Because again, the evidence tells us that once you move to the city to study and you become embedded with your social circles there, that often the capacity to come back and work in rural becomes less over time. We need to see more supports for the early career allied health professional working in rural and remote areas to make sure they can have a successful and positive experience working rurally. And so what we'd like to see New South Wales take on is a statewide approach to the Allied Health Rural Generalist Pathway, which is something that has been established in other jurisdictions, and we'd like to see a formal and statewide approach taken by New South Wales Health to to implement the Allied Health Rural Generalist Pathway in local health districts. And finally, and I'll let Essa, my colleagues at Essa, speak in a moment. More closer links with academic institutions, so that we've got increased capacity to undertake and build the evidence base in rural and remote communities. So New South Wales Health does run some great programs along those lines. We need better access for allied health professionals to participate in those programs.
Thank you very much. We'll move now to the questions from our crossbench members. Deputy Chair Unrehearsed.
Thank you, Chair. I just want to start with a couple of questions, either for Ms. Evans or Mr. John Stevens. One of your recommendations is that the New South Wales Health Minister commit to spending at least 5% of the New South Wales health budget and each local health district budget on public health initiatives. I just wondered if you could sort of unpack this a little bit for us, try and get an understanding, where you got that figure of 5% from, and also what effect that would have on the ground if that was to take place.
Thank you. Just a few comments. That 5% figure is a figure that's been adopted already by the Western Australian government. It did a review of health expenditure a couple of years ago, and the findings of that review was if health expenditure patterns continue, health budgets are becoming more and more unsustainable. So the 5% figure is a well thought out, considered figure in terms of investing in prevention, with a view that greater investment in prevention will prevent a lot higher expenditure at the tail end in terms of dealing with people with chronic conditions. So that figure, for example, is a priority widely acknowledged in public health circles. John may like to speak just briefly in terms of the impact of treating people early in the progression in terms of a chronic disease.
Thank you.
Certainly, if I may,
please.
It's quite well established that end-of-life care is where a considerable amount of health budgets are spent, and unfortunately, when we lack the funds or the incentives within schemes for early intervention or even secondary prevention therapies to be implemented, we see inevitably costs escalate as patients continue through a unregulated disease progression process. We know pretty robustly that non-pharmaceutical management by dietitians and exercise physiologists can reduce diabetics' risk of further escalation on par with medication, but we don't see incentives or funding commensurate with the resources that allied health professionals can provide compared with, say, the resources assigned to the pharmaceutical benefits scheme. We know that we can diminish rates of hospitalisation and exacerbation in patients with chronic respiratory conditions, but we routinely see in rural and regional communities funding for pulmonary rehabilitation and pulmonary maintenance programs, which are well supported by organisations like the Lung Foundation, not supported by funding in order to help people often experiencing disadvantage either by rural or geographical or socioeconomic means from accessing services that would otherwise help them. So I guess the evidence is there for us to see. The relevant modelling wouldn't be hard to attain, but the will to implement these changes is what appears to have failed us to this point.
Thank you. And do you think that New South Wales Health and local health districts can better integrate and support your work to ensure greater access in rural and regional areas, sort of beyond funding as well?
Most definitely. There are issues in terms of the interface of public patients who come into the public system and then referrals into the private sector. And we're aware of current policies which disallow public practitioners from providing referral pathways for patients. So there are interface issues there. There are also issues in relation to the sharing of patient data, and we draw your attention to the viewer, which is a model established by the Queensland Health Department, which enables the sharing of public patient hospital data with, at the moment, private GPs, but there are moves underway to change the regulations to allow private allied health professionals to have access to public health patient data. My colleagues may have other points to add on that.
Thank you very much. We'll move now to Kate Fairman.
Thank you, Chair, and thank you all for appearing today and for your submissions. And just there are a lot of really excellent recommendations in the submissions, and a fair few of my questions have actually been answered in the your responses to previous questions. I did just want to ask then, because it really is frustrating in terms of the recognising that in some ways the answer and the solution is so simple in terms of spending more on wellness and exercise, as you're also talking about. Who is within New South Wales Health specifically? Are you kind of working or advocating for greater funding within New South Wales Health or with the Minister? Has there been any progress? Because I see recommendation 1 of the Exercise and Sports Science Australia's submission. Recommendation 1 is that at least 5% of the New South Wales Health budget and each LHD's budget being spent on public health initiatives. I'm assuming there's been some advocacy over several years to try and get an increase, and I'm just keen in terms of hearing what the response is like, or is there any traction within government already on this?
We work closely with Leanne Evans again. We work closely with the New South Wales Chief Allied Health Officer, Andrew Davison, and his colleague Nicola, the Manager of Allied Health Workforce. So we've been, yes, it's fair to say, we've been pushing for that for a number of years. At this point, it's fair to say we haven't had a lot of traction. I mean, it's a completely different way of looking at health budgets, and from our perspective, it's probably fair to say that people within the hospital system have a lot greater authority and clout probably to ensure that the status quo prevails. So it's a difficult process. But we're not the only organisation that is asking for that target to be set. So the Public Health Association of Australia, for example, is leading the charge in respect to its policy priorities. So, we're aware of a number of chronic disease or health promotion charities that also have that target as one of their priorities.
Yeah, thank you. And is the 5%, what is it at the moment? Do you know, Leanne?
On the figures that I've done nationally, it's around 1%.
Yeah.
Like we're well down the OECD list.
Yeah.
So any increase, and to be fair to the Western Australian government, they've made a commitment to achieve that 5%, I think, over a 4 or 5 year period. It's not something that, they are moving to in a single financial year.
No. I'm interested in the exercise is medicine training. So who that exercise is medicine, who does that at the moment?
That's an ESSA supported program in conjunction with a number of stakeholders. So that's offered free online to any health professional across Australia. And it's also accredited by the Royal Australian College of General Practitioners and the peak professional body for primary care health nurses. So that's something that we promote on an ongoing basis as a means to increase the level of health literacy around the value of prescribing exercise.
So at the moment, that's voluntary. There's no, and one of your recommendations is that the making this a requirement as opposed to at the moment. So what's the take up at the moment? Do you have statistics on how many physicians or allied health professionals do that?
I can take that on notice and come back to you with the figures for New South Wales.
And sorry, I just realised that the recommendation is about the rural adversity mental health coordinators. So that's obviously drawing a link between exercise and mental health there.
Yeah, but equally the value of EIM can be applied to any health professional,
yes,
including nursing as well as medical practitioners.
Mm.
Thank you very much.
Absolutely, thank you.
Thanks, Kate. Moving now to government member, Honourable Wes Fang.
Thank you very much, Chair, and apologies, I am at this section. I don't know if you can see me, but I'm just off to the side of your camera. Ms. Evans, I've had the opportunity to chat with you previously, and I noted from our conversation you were able to provide some examples around the difficulty in actually getting the training that's required for exercise physiologists in rural and regional settings, because we know that if we train medical professionals of any type, whether they be doctors or allied health, that they are more likely to stay if they've got exposure to rural and regional areas. Do you think you could actually provide the committee some examples of how that difficulty occurs and what you think we might be able to do around fixing it?
Thank you, Wes, and I bring to the attention to the committee a early career graduate that I spoke to from Wagga. She basically quit her job after 2 years. She was the sole exercise physiologist in the local health district, and as a consequence of that had no local mentoring or professional clinical support. So that's one example. In terms of some of the solutions, one is the capacity. So the senior staff that are already, senior allied health staff that are already in the New South Wales health system are working to capacity. So that was an issue that we're conscious of. It's not necessarily that they don't want to supervise students. It's just in many cases they are simply working to their absolute limit and don't have any capacity to supervise staff. And the other issue is that there is just a lack of senior clinical roles in exercise physiology across the state generally. So part of the solution to that is that senior staff in other health districts can provide cross-district clinical supervision, and we've seen examples of that. But again, that is inconsistent, and we'd love that to be more of a consistent policy across all local health districts.
Now, I noted, I think somebody had raised their hand on the system. Ms. Maloney, are you able to provide some further insights? I think you're on mute again, Ms. Maloney. I've always wanted to say that. I've never actually had the opportunity to tell someone they're on mute. So thank you for that.
We actually like to say to Mr. Honourable Wes Fang that you should be on mute, but we don't get to say that. So, I'm only joking. Honourable Wes Fang.
Well, thank you, and I'm glad that I was able to provide that opportunity for you. And I can speak from experience as a former director at Allied Health within a rural local health district, and I empathise with that former employee, the exercise physiologist who wasn't able to access direct supervision. There are some governance supports and resources in place within each local health district. There's usually very little funding made available to allied health professionals to enable adequate access to supervision and support. And so even where you see a need, where there is a sole practitioner who needs to be networked with other professionals of their discipline, you often don't have the resources to actually do much about that, and you are relying on the goodwill of your existing employees to provide, whether it's within discipline or cross-discipline supervision and support to sole practitioners across rural health services. And as my colleague Adessa said, that these people are already working to capacity and are stretched, and so there is no capacity within the system to enable adequate supervision and support for allied health professionals, and this is why they often burn out and leave the health service.
So it seems to me that there's often a reliance on, I guess, the level of goodwill provided by colleagues and supervisors to actually provide that collegiate support to whether it be trainees or newly minted people that are coming into the sector. And if they haven't got that, particularly in a remote, rural area where they perhaps haven't got that collegiate support, it makes it very difficult. Is that a fair assumption as to the problems?
Yes, absolutely. That's part of it, and part of it is, and we see this with our membership both within health services and in private sector, because there is such an overwhelming unmet need for allied health services in the community, that allied health professionals feel under pressure to continue to provide those services and take very little time out for themselves to develop themselves professionally and to undertake those self-care functions that we know is so important to maintain their health and well-being, their own health and well-being. So it's partially a demand issue. It's partially that there is no resource set aside specifically to support allied health professionals. I mentioned in my opening statement the fact that there is no budgeting for backfill for allied health professionals, so that when they go on leave, an entire service can fall over for that period of time.
Ms. Evans actually addressed that with pressure. Ms. Evans actually addressed that point to me earlier as well, which I found very interesting. I know my time is up, but I'm going to sneak one more question in just while I've got you. So, would it be fair to say I'm doing a waltz record and just sneaking one more in? Is it fair to say, do you think, that in reality, instead of recruiting the newest, youngest graduate from a program into a rural and regional area because they perhaps are available and they may not be experienced enough to, say, get a high-profile job in a metropolitan area, instead of recruiting those people into rural and regional areas, what we really need to do is have a targeted recruitment campaign around very senior, experienced people that can actually kick off the start of what would be a mentoring role, where we then get those younger people come in, they're mentored, they then stay, allowing the other more experienced people to retire, and then we've got that sort of continuity that they can then mentor the next generation. Is that what, I guess, that circuit breaker that we'd need to fix that? And Ms. Maloney, I can see you actually raising your hand now, so, and I'm not sure if you're on mute, but by all means, you've got the call.
Thank you, and I think I'm not on mute, so thank you. Simply put, that's a great strategy, but those senior clinicians do not exist. So there was, I'll give you an example of that, where we did implement a trial of the Allied Health Rural Generalist Pathway in the Murrumbidgee Local Health District, which was addressing this issue about how we support junior allied health professionals into some of these sole practitioner roles. And we cobbled some positions together to create a senior position whose sole job it was to support 3 junior physiotherapists in this instance, and recruit to 3 very chronic vacancies within 3 different locations across the Murrumbidgee. That was successful in that within a few months all of those positions were filled, and the senior position this was a novel position within New South Wales Health in that their sole job was to provide supervision and support and service delivery support to these junior allied health professionals. The funding didn't continue though, so now they are, my understanding is, still in contact with those local allied health professionals, that program hasn't continued and those vacancies have arisen again. So what we need to see is that ongoing support made to allied health professionals to build that experience and seniority. Apart from the fact, and I will just add that there is a tendency as a position becomes vacant to revert it to the lowest level of pay. And, you know, as a Director Allied Health myself, I had to fight to maintain that level 3 sole practitioner rating in some of these positions. So there's this constant tension between what can be filled because we only have access to early career allied health professionals in general, and the need for seniority and experience in these positions.
Thank you very much. I really appreciate it. My time is up, but thank you very much for appearing. Oh, Mr. Johnson, if it's a very quick one.
No, please proceed. Yep.
Very quickly. It also becomes a clinical quality issue when we can't have supervision, we can't get adequate clinical vision, our junior clinicians, who then feel obliged because they're seen as fully formed clinicians once they graduate, and that's it. That's all you learn. We know from nursing and medicine that training goes on for many years throughout your career, but this doesn't seem to happen in allied health, and there's not that recognition. And non-allied health managers of those junior clinicians then often put pressure on those clinicians to work in areas of clinical competency which they simply don't have.
Thank you very much. Thank you, Brian Roisfang. So on behalf of all committee members, thank you very much. That was a very, very worthwhile session, rich with detail and information that adds very nicely to the detailed content of your submissions. So that will obviously inform our deliberations in regards to the preparation of the report and the recommendations that we'll be producing. So once again, thank you all very much for carving out some time on your busy day. We appreciate it very much. Thank you.
Thank you.
Thank you.
That brings us to the luncheon adjournment. So we break now, and hearing will recommence at 1:10 p.m. Thank you. Everybody to the afternoon session for today's hearing into our inquiry into health services and health outcomes in regional rural and remote New South Wales. We'll get underway. Not all committee members are here. They'll be on the way shortly, but we can get through the, we'll get underway at least the formalities of the swearing or the affirming of the witnesses. And can I welcome our first panel of witnesses this afternoon. And can I say it's great to have two witnesses in the room. We've been all remote today, so we've actually got people in the room and people remotely as well. So it's good to have you as well. So
I've never seen Hansard so happy.
Yes, we've had Hansard find it a great deal easier to be able to sort of not quite lip read, but follow more closely what you're saying, because I can hear you firsthand. There is a slight delay on the transmission over the internet, but nevertheless, it's great to have you, four of you, here this afternoon. So the first part is to deal with the formality, and that involves for each of our four witnesses each to say their full name, their position, title, and who they're representing today, and then swear either the oath or the affirmation, whichever you prefer, the words of which should have been provided to you. If for some reason you don't have those words, put your hand up and provide them to you. The easiest way perhaps for me to proceed is just through the room virtually. So perhaps if we start with Dr. Bell. Is that okay? Oh, I'm sorry. Wow.
You were pointing over there.
It's been a busy week. Sorry. I've been told 3 times who's who, but let's start with Dr. Raphael. Pronounce that way, or Raphael?
Do I have to?
Thank you.
Oh.
So please proceed.
Thank you. Dr. Sarah Raphael. I'm the Advocacy and Engagement Executive at Australian Dental Association New South Wales.
Thank you.
I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you very much. Dr. Jonas.
Yes, I'm Dr. Michael Jonas, and I am President of the Australian Dental Association New South Wales branch, and I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much. We'll now move to our witnesses. Dr. Bell.
Dr. Kristen Bell. I'm Head of Department of Ophthalmology Department at the Royal Hobart Hospital. I'm RANZCO Regional QEC Chair, STP Committee Chair and Equity Coordinator.
Thank you.
And I'm representing RANZCO today.
Thank you. And would you please take either the oath or the affirmation, whichever you prefer?
Absolutely. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thanks, Dr. Bell. And Associate Professor Agar.
Thank you. I'm Associate Professor Ashish Agar. I'm representing RANZCO. I'm part of the Outback Eye Service in Western New South Wales and also RANZCO's Reconciliation Officer.
Thank you.
And I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth. Amen.
Thank you very much, and thank you, Associate Professor Agar. Now, what we normally do is we provide each of the groups an opportunity to make an opening statement through one of their witnesses. If you decided to split the opening statement between yourselves, that's okay to us. We just need to know that in advance. And then once that's completed, we'll move to questioning from committee members, if that's agreeable, for the allocation of time. So are we happy with that outline for this afternoon? Well, thank you very much. Well, we'll commence with the Australian Dental Association and their opening statement.
Thank you.
Thanks.
So thank you for the opportunity to address this important New South Wales parliamentary inquiry. As I just said, my name is Michael Jonas and I'm President of the Australian Dental Association New South Wales branch. We are the peak body representing the dental profession in New South Wales and the ACT, and our membership comprises over 70% of the registered dentists in that area. For over 30 years, I was a private practitioner in Gunnedah, so I know only too well the oral health issues our rural and remote communities face. I could tell you pretty much to the minute when a patient sat down in my chair whether they had been exposed and had been drinking fluoridated tap water, as distinct from tank water, it is almost day and night. Currently practicing in Tamworth, I see improvements that access to fluoridated water and oral health services offers, but there's still a long way to go. Currently in New South Wales, there are over 85,000 adults on the public waiting list, and about 30,000 of these are in regional, rural and remote areas. These communities struggle with the lack of specialist oral health services, long public waiting oral health lists, as well as longer travel times and limited transport options. Many remote communities rely solely on the Royal Flying Doctor Service for dental treatment, and while they do an incredible job, they cannot offer any continuity of care as so many city folk enjoy. The more remote you get, the less chance you have to access to clean, fluoridated drinking water, fresh, healthy foods and oral hygiene products, and the patient-to-dentist ratio nearly triples. Good oral health is fundamental to overall health and well-being. Tooth decay and gum disease cost billions of health dollars each year, and this is without accounting for the wider health consequences of poor oral health on chronic diseases, including diabetes, cardiovascular disease, lung conditions, adverse pregnancy outcomes, and the list goes on. What does good oral health actually look like? The expectations can vary widely depending on a person's circumstances, but what is undeniable is that every Australian deserves the ability to smile, speak, and eat without pain. After all, no one expects a child to just put up with an earache. So why should they put up with similar conditions in the mouth? To improve oral health for rural and remote residents, there are a number of existing programs and schemes that ADA New South Wales recommends government build on. These include addressing workforce issues, facilitating teledentistry where appropriate, and promoting the Child Dental Benefit Schedule to improve the current uptake from only 37%, which we'd see in our rural, this would see our rural and remote children get off to a much better start. The picture of oral health that I have described is not a luxury, but it's a basic human right that cannot be overlooked. New South Wales ADA pledges to support the much-needed improvements and will work with policymakers, healthcare administrators and our profession to continue to advocate for a better deal for people in these communities.
Thank you very much. Well, thanks, Dr. Jones. That's very good. That builds on, and I should have mentioned this, and I was remiss to do so at the start, to very, very helpful submissions that have been made to the inquiry. Ramsco's submission is submission 271, and the Australian Dental Association New South Wales Range 714. Both of those have been received, processed, and now stand as submissions to the inquiry and have been uploaded to the inquiry website. So thank you for those. And today's testimony obviously builds on top of the content of your submissions. Can I now pass over to Ransko for an opening statement? Who'll be making that?
I'll start the statement and then we'll switch over to Ashish.
Certainly.
Okay?
Certainly.
Yeah. So, Ransko thanks you for the opportunity to appear before this parliamentary inquiry. We note that timely access to eye health prevents 80% of permanent visual loss, and we tabled the Lancet Global Health Commission on Global Eye Health, which notes vision impairment exacerbates dementia, increases falls, car crashes, the need for social care, and mortality, and finds eye health as an essential component of universal health coverage. It must be included in planning, resourcing, and delivery of healthcare. We tabled the true cost of hidden waiting times for cataract surgery in Australia, which documents inequitable access and long waits, and we recommend New South Wales Health funds equitable access to public cataract surgery, noting we save money. But cataract surgery only comprises 20% of eye health. The other 80% being delivered in eye clinic and essential to prevent blindness. New South Wales Health mostly does not deliver eye clinic services in regional New South Wales, despite these services being eligible for public hospital funding. Timely access to outpatient services adds value by preventing hospital admissions. Rankin recommends mandating eye outpatient delivery in all districts and public reporting of waitlist data. RANZCO also recommends New South Wales Health develops a centrally administered e-referrals portal. New South Wales Public Ophthalmology FTE is insufficient, with stagnant growth causing inadequate service capacity and threatening workforce stability. RANZCO recommends New South Wales Health develop KPIs and increases funding for public ophthalmology workforce. We table the proposal brief RANZCO regionally enhanced training network and appendices, which has federal funding but requires state investment to actualise, which we request. Atish.
Thanks, Kristen. So look, there is even more that we can do to try and fix this problem. Some of these are really quite simple solutions. For example, if we were able to list indigeneity as a comorbidity when waitlisting someone for cataract surgery, we can actually help our First Nations communities access surgery in a more effective manner. Another proposal is for an agency for telehealth in-reach outreach services. So this would enable the regional workforce, whether it's an emergency doctor, a GP, or a colleague of ours in the regions, to actually be able to be supported. There are other measures that are more longer term, and we tabled the National Health Reform Agreement, the long-term roadmap, which provides a framework for New South Wales Health to be able to actually map and detail the existing services. That would allow us to then plan for the future. And we're not talking about a year-on, year-out plan, but 4 to 5 years worth of planning, which could actually address these gaps. And there are existing services to areas where there is no ophthalmology present. We have outreach services already, and these need to be funded by New South Wales Health. We recognise, though, that all of these plans, they need to have clinician involvement up front, at the design stage, not at the end, without which these plans invariably fail. I've had the honour and the privilege of working in Outback New South Wales for 20 years now, and it is easily the best part of my job. But you'll forgive me, honourable members, if there's a sense of deja vu and, dare I say, scepticism about yet another inquiry. We've seen and heard all of these messages before, and we're still having to ask the same question. So RANZCO asks with the greatest respect whether this inquiry will be any different. Will the government commit to meaningful and real change that will enable our community to keep seeing? We welcome the establishment of a parliamentary champion for eye health, and I think we really need to join forces and address this, because without this, the right to sight will be lost in your New South Wales. Thank you.
Thank you very much, Associate Professor. So, can I just say, I appreciate those comments you made about another inquiry, but we're determined as best we possibly can to utilise what's been a lot of evidence we've collected to produce this report over the Christmas New Year period into January, February, and with some strong recommendations back to government. So we sincerely hope the government will look at those and examine them closely and hopefully adopt them. So we'll move now on to questioning, and we'll move between the opposition crossbench and government members of the committee, roughly 10 minutes for each grouping, so thereabouts. So we'll start with the Honourable Walt Secord from the opposition.
Thank you, Mr. Chair, and thank you all for your submissions and your opening statements. Dr. Jonas, Dr. Raphael, so I want to make sure I get this correct. You said 85,000 people are on the waiting list for dental. Now, what is the length of time on the waiting list? Is it months? Is it years? Can you give me a bit of context?
Sure. It's very variable from one LHD to another. Generally, adult waiting lists are very long, and then again, it gets split between sort of some emergency care waiting lists versus some comprehensive care waiting lists. But there are many cases where people are on waiting lists for up to 2 to 3 years.
Now, when you're on the waiting list, to get on a dental waiting list, do you have to have major problems?
No, you need to be an eligible adult. Yep. All children up to 18 are eligible, but you need to be an eligible adult, so you need to hold a healthcare card or a pension card of some description. but no, that if you've got pain of varying severity, it will place you on a waiting list of a certain length of time. So if it's intractable pain and facial swelling, you need to be seen within 24 hours. If it's pain not quite that bad, it will be a longer period of time. But for comprehensive, if you just want a checkup and you're an eligible adult, you could be waiting 3 years for that checkup.
And almost, about 40% of those people on the waiting list are actually in rural and regional areas. So
where there's much fewer services.
Well, I was going to get to that. So is it those 30,000 people are on the list because there are fewer dentists in rural and regional areas? So you wouldn't be able to actually get them through on procedures because there wouldn't be enough dentists in those areas. Is that correct? Or am I misunderstanding the situation? Mr. Jonas?
If you don't mind, that's close to the point. However, if the workload was spread across the available practitioners, that would be alleviated a lot. Like the government schemes that addresses emergency treatments, the Oral Health Fee-for-Service scheme, which operates quite successfully for emergency care, with collaboration with private practitioners, for instance, you would get those waiting lists significantly decreased. But at the moment, all patients present to a public clinic, which is usually associated with a local hospital, and then they're sequenced from there. So it slows down.
So the 30,000 people in rural and regional areas that are waiting for dental treatment, are they in fact people who are waiting with more complex or in fact greater problems than people in Sydney, in Sydney, Wollongong, Newcastle? No? Yes?
No, I'd say it's much the same.
Much the same, right. Now, the 30,000 people that are waiting, so that is not spread across the state. There would be certain areas of the state where there, in fact, would be no other local government areas or sections of the state where there are no dentists whatsoever.
As in public dental facilities?
Yes.
Well, I can talk about my own situation.
Yeah,
in
you're from
Gunnedah,
Tamworth, aren't you?
I am in Tamworth now, which has got a fantastic facility. I had the almost the joy of having a look at it about 3 months ago, and it's quite something. It's really something to be proud of. But in Gunnedah, where I worked for 30 years, there is a clinic, and it gets manned 1 day a week, and it gets manned from a dentist who comes over from Tamworth, depending on workload. Now, Gunnedah is a town of 10, 11,000 people, so it's 15,000 people.
So there'd be enough work there?
For someone full-time, it would be maybe stretching it a bit, but you could easily have that split with Gunnedah, and there's a number of out clinics too. There's one in Narrabri, but they're around there's a lot of them around the place, but they're not staffed adequately.
Are there enough, okay, if you had a magic wand and you were able to say, are there enough dentists in New South Wales to staff the areas of need?
Yeah, absolutely. It's a maldistribution. It's not a workforce shortage. It's about finding the right incentives for people to go and work in these areas.
Okay, but when you're talking about incentives, you mean people who want to work in the public system. Is that what you mean? Is there
public or private? I mean, it's equally as difficult to find a private dentist in some of these areas as a public one. And I guess that Michael alluded to the oral health fee-for-service voucher system.
Yeah.
If there was some assurity for practitioners that they would be given a certain amount of their work time doing work through the voucher system, then it might make practices in some of these regions sustainable, and it might be an incentive that gets people to move to the bush, basically.
So do you find that because of the lack of dental treatment in rural and regional areas that people, in fact, are not doing, how do I say, restorative or preventative? They're just simply pulling teeth? Or am I oversimplifying it?
No, the treatments usually are episodic, like as you described. But a huge cohort of those people end up at their GP, who are overworked anyway, and they get a GP diagnosis, which is fair enough. They get antibiotics, they get painkillers, and they leave, and 2 days later they're feeling a lot better until they don't, and they go back through the cycle again. So you'll find these people do go through, and we finally get to see them, and this process could have been going on for 18 months, 2 years before it got to that intractable situation. So there's an economic argument almost to decrease the amount of treatments as a result of having people there.
Now, in your opening statement, you made reference to fluoride.
Yep.
Do you know how many communities in New South Wales that could have fluoride in the water supply but do not have fluoride in the water?
So not exactly, but we know of several councils who have now approved, and it's been gazetted with New South Wales Health, but the process then of implementation and staff training to implement the fluoridation plant is very long and protracted. So, for example, in Molong, New South Wales, that process is over 10 years, and they still haven't got fluoride flowing through their water system.
Is it hard to put fluoride in the waters? Isn't it just a matter of putting it in?
It requires the water system to be upgraded, which New South Wales Health pay for, so that bit's done. But usually the stumbling block in many of these smaller areas is that they can't get qualified people to do the monitoring and the dosing.
Oh, I see. So I'm sorry, I'm just mindful of time. So if the state government was to invest in support systems to improve fluoride in country towns that need water, would that in fact help dentists, help people who have prevent bad teeth happening, and improve general health?
Well, I think the general statement can be said that the best form of dentistry is prevention.
Yep.
And that would be perhaps the biggest step forward in prevention, without a doubt. We get fluoride from lots of other areas because, work in Gunnedah, it still hasn't fluoridated. It's to be done, but it still hasn't been done. But I used to see...
Gunnedah doesn't have fluoride in the water?
Not yet. I mean, it's already been gazetted. It's going to happen, but they still haven't built the plant. So there's lots of things happening. But it's there. We've had the battle, which was a very interesting thing to take part in. But yes, it would certainly help a lot. But not all communities are really a size big enough. Or am I right?
I understand that.
To do that.
And also, we're at the point where approximately 95% of New South Wales people have access to fluoridated water. So it is quite a small number. But that 95 would take in the ones that are gazetted, but it hasn't happened yet, if that makes sense.
Can I ask one more question? I'm sorry, other members will have to ask the I questions, but I'm sorry, I just realized I've run out of time.
All right, we'll cycle around again.
Okay. So back to the waiting list and that. So what would be a recommendation, or what is the best thing that we could recommend to the government to cut the waiting lists in rural and regional areas? Is it more vouchers to get people to private dentists, or what's the best approach?
Well, that certainly would, I don't know about more vouchers, but a more equitable and collaborative approach. I can tell you from my experience, I had 12 months working in Gunnedah where we had a system like that operating, where we had a budget to work for, and it worked brilliantly. And they just trusted the practitioners to do the right thing. So there's a huge element of trust in this, of course. So that would certainly work. Just getting people to use the child benefit dental I can't even get the words right. Schedule, anyway, CDBS right, will make a huge effect.
How do you feel?
37% uptake.
I was going to say, how do you feel as a dentist when you see children under the age of 5 coming in with rotten teeth?
Well, I can tell you, I spoke to one of my colleagues yesterday, and she did a GA list, and one of the children had 8 teeth removed. How old was she? About 8 or 9. So this young person had about 60 or 70% of the remaining teeth removed. They were deciduous baby teeth, but that being as it may, quite often a preventable situation, very traumatic, very painful. But going through the process to get there and getting general anaesthetic services, that's another story altogether.
And that was in Wagga Wagga?
Yeah, that's in Wagga.
In a major town?
Yep.
Wow. Thank you. My time is... Sorry.
Thank you very much. The Deputy General, William Hurst.
Wonderful, thank you. And I might start with Dr. Bell and Associate Professor Agar, and still wanting to sort of talk about those long waiting times. Obviously with eye issues, they often need to be looked at quickly, and deterioration can be quite fast. Do you see long waiting times to see ophthalmologists, and what does that mean when you finally get to see a patient? Like, does their condition is their condition often a lot worse and more difficult or expensive to treat than it could have been?
Yeah, Kristen?
Well, yes, and in fact, even though you sort of think about cataract surgery, when you think about ophthalmology, it's only, as I said, 20%. We're dealing with diseases, glaucoma, macular degeneration, and diabetic retinopathy. And, if they're not treated in a timely manner, you get the permanent loss. You can't get it back. And it also results in very high-cost treatments being needed. And so it's quite frankly a disaster for the patient and community as well. All the flow-on costs for looking after somebody who's visually impaired, and we don't even have outpatient services in regional New South Wales, or very few exceptions. So we don't even get to see a waiting list. If you can't afford the private care, or there's no private care, then you need to go into the city. If you end up waitlisted for surgery in the city, then you also have to travel there for surgery. And the wait lists for cataract surgery in the city are very long. And you're talking, 3+ years just to get onto the clinic, and then once you were on the inpatient wait list, so the wait for the wait to get into the clinic, and then once you're on the inpatient wait list, another year or so in some areas. So it's a huge problem. We don't even have outpatient eye clinics in Wollongong, in Nepean. We don't have them in Gosford. We don't have a decent one in John Hunter Hospital. We're most of our public outpatient clinics are centred in central Sydney. And, it's a huge problem with huge ones.
Next door.
And you were talking about the fact that obviously a lot of these people are having to then transport to Sydney. Obviously, when we're talking about people with vision issues, that transport obviously is an even bigger issue. How do we deal with that situation on top of the fact that they're already having to travel, but the fact that some of these people might be vision impaired and not be able to transport themselves?
Also, another huge issue, we don't have great public transport. The patient transport scheme doesn't cover people that are not acute at the moment, as far as I'm understanding. Community transports cost money, and so there's huge issues. Carers have to take time off. It results in economic losses to the community when people have to travel in and spend money elsewhere than regional Australia. But really, we do have regional ophthalmologists in many areas. They're workforce short, and they do bulk bill a lot of patients. But one of the problems is that with Medicare benefits not being indexed, the actual value of the Medicare benefits has dropped. It's about 40% of what it was in 1984. And then it's like patients are in a bit of a just no man's land. If they're socioeconomically disadvantaged, they're dependent on a practitioner bulk billing them if there's workforce in the area. There's no public hospital services in terms of outpatient clinics, and so there really nowhere for them to go. And then they need to wait for long waits and go into the city for their care if they can't access it in the community. So it's a public health disaster, really, with huge long effects to the community and cost burdens. And it's, And
why do you think that ophthalmology is being overlooked as an essential health service?
There seems to be this almost like bunker mentality when it comes to outpatient services that we've observed, where if you can just stop them coming in the front door and just delay them getting into the outpatient clinic, then you can control your inpatient wait list. And certainly I've heard that in numerous jurisdictions from business managers. And probably the irony of the whole thing is that when you do that, when you delay access into the essential services, the outpatient services, you actually end up causing costs. So people fall over, and elderly people fall, they end up in nursing homes and care. There's morbidities and mortality just from breaking your hip. They have car crashes. And it's not just eyes, of course, it's right across the other medical specialties. COVID taught us anything. It's taught us that if you don't see your doctor regularly, you'll end up increasing the inpatient admissions. And we've seen that flow-on effect around the world and in Australia. When people don't get their regular care for their chronic conditions, and 1 in 6 Australians has a chronic condition, then they will end up increasing the inpatient admissions, which is where the huge costs are.
Thank you.
Thank you. Kate Fairman.
Thank you, Chair. I think for you again, Dr. Bell, with the your submission, I note that one of the summary points actually was around, again, Aboriginal and Torres Strait Islander, the single biggest risk factor. Sorry, I'll start again. You have said in your submission that Aboriginality is the single biggest risk factor for vision impairment and blindness in regional New South Wales, and then that mechanisms to expedite services for patients identifying as Aboriginal and or Torres Strait Islander should be considered. I mean, it's quite extraordinary to hear that there aren't already any mechanisms to expedite services for First Nations patients. Is that the situation?
Yeah, from a New South Wales health side of things, no, it's not. So back in 2012, the Chief Medical Officer of Australia, following some engagement from Indigenous Eye Health, agreed that access to cataract surgery for Indigenous people should be prioritised. That was taken around all the various states. Queensland took it up and has used indigeneity as a clinical modifier for categorisation purposes on wait lists, which I think, there's a number of barriers to that. What you've got in with this LHD system, which is great because care should be on the local level, but there's not a lot of governance over the wait lists. So you have an issue where you have patients on multiple wait lists. You can't really see what's happening with the wait lists outside that local health district. And having a mechanism where you could have central oversight of wait lists with a central e-portal to actually deliver, a cohesive health information, system that would assist managers, and then allow oversight of the LHDs to actually see what they're delivering in each LHD. I mean, at the moment, we have the National Health Reform Agreement, and one of its, key, things that it's trying, that it says it wants to do, is to basically give equity of access to care. And yet, despite that being a key objective, it's really left up to each LHD to decide what services will be delivered within the area. And it's an ad hoc approach to delivering equitable services. And what we really need is a central process, wide engagement. Let's work out what should be delivered in each area. Let's calibrate it for geography, calibrate it for demographics, and then provide LHDs with a detailed map of outpatient and patient services which should be delivered in the area, and then observe.
Yeah.
So, organise.
Thank you. And are you aware of any outreach services, if you like, that specifically go to some of the remote communities in far western New South Wales?
Yeah, and we have a great one. I'm going to hand you over to Hashish, who's going to
Great.
tell you all about it.
Yeah, thank you. So I'm part of what's called the Outback Eye Service, which is based at the Prince of Wales Hospital. And this is the legacy of Fred. Now, not many people recognise by one name, but Fred is. So Professor Hollows, of course, really took the bull by the horns and started this program in the 1970s. And we have, under our current leader, Professor Pronio, expanded this to cover almost 2/3 of New South Wales. So west of Dubbo, we are the only public ophthalmology provider for the state. And it's been tough. It's something that we are constantly having to fight to justify our existence. But I can say with confidence that, for a large part of the state, we are able to actually meet a lot of these needs. We talked before about what happens when there's no public service, but by maintaining a public ophthalmology presence in these areas, we are actually able to prevent people getting blind. And I guess as a as a counterpoint to some of the problems, it's important to see what happens when a system works. So, you know, in the places where I work, say, even somewhere like Broken Hill, when you have good engagement and when the executive works with you and administration is working with you, which they do with us there, we are actually able to achieve incredible things. Over the COVID pandemic, the eye service was the only specialist medical service that was uninterrupted. Through the first wave, the second wave, Delta wave, we managed to keep people from going blind in the bush. And that was because one of the big obstacles to a public service was actually ameliorated by having a really good engagement and an executive and an administration that actually listen to us. So these services are amazing, but they're not funded by New South Wales Health. They're on year-to-year agreements. We could fall over tomorrow, and we'd have patients from Burke to Warrana to Broken Hill to Lytton Ridge. We'd have nothing left. So even we're precarious, despite going for.
Will you let Kate do a follow-up question?
Yeah, thank you. Is it? Can I just follow up? Just a quick follow up on the funding because I'm glad.
Don't rush.
Yeah,
Feel the need to
thank
rush.
you.
Yeah.
Just.
Can you put the report as well?
Yes, we've got a few.
Sorry, there's a report on the Outback Eye
Take the Outback Eye Service report, please, as an example.
Yeah, thank you.
There it is. And so with the year-by-year funding, because I was going to ask that, so you saying that it's funded largely through the Fred Hollows Foundation and then it's a year, no? It's
through the Commonwealth.
Okay, but it's year-to-year then in terms of and it's a contract with the Commonwealth or with the New South Wales Health? Yep, with Commonwealth, yep. Wow. Nothing from New South Wales?
There's no certainty.
Yeah.
There's no certainty that the next year it'll even exist. So it's been a battle just to stay alive, despite looking after, 2/3 of the state.
And what's that? Is the contract, the figures in here, is that able to be shared or?
Yeah, it's about, so to cover the whole service, and I have to stress this is comprehensive, so we're not just talking about one type of disease, it's every specialty within ophthalmology. It's about $500,000 a year to cover 2/3 of the state.
Wow. Gosh.
Not a lot of money.
Yeah, thank you. Thank you.
Thank you, Kay Fairman. The Honourable Wes Fang.
Thank you very much, and thank you to all the witnesses for appearing today and for your comprehensive submissions. It's really appreciated. I must declare that I know Professor Carreño. I've had a connection with him for some time, so I very much appreciate the work that happens with the Fred Hollows Foundation. Just on that, though, you said that it's predominantly funded through the Commonwealth. Is that correct? And the contributions that the Commonwealth makes, they're, I guess, renewed every year. Is that how much warning do you get that the Commonwealth is going to reaffirm the commitment for the next year?
Well, look, it's funny you ask that because as anyone who works in any area of public health or for that matter education or research or anything that's based on a year-to-year commitment knows, you spend half a year trying to get the money for the next year. So you have notice, but essentially we're just writing reports and having to justify our existence every 12 months.
And in relation to the area that you cover, obviously you've said I think 2/3 of New South Wales of the far west of New South Wales. Do you cover areas past the border into other states as well?
That's a really good question. So, for example, at clinics up in Burke, we will see overflow from Queensland. So, places like Goondiwindi and these places that straddle the border, they will feed into us. Less so in Broken Hill. And, of course, there have been a whole bunch of issues with that, with the border closures. But, yeah, it's not limited to the state lines, and we will see all comers. So, in effect, what you're doing is providing a remote service from the metropolitan area, but it really is
spanning across the border and picking up a lot of those remote communities, but acting as a magnet almost to the service. Is I was going to say, is there a similar program that's operating in other states that is being implemented, say, by the Northern Territory or South Australia, or is this really unique to Australia?
Look, it's not unique. It's the first one, and so it's been going the longest. But our colleagues in WA and in Central Australia, they run similar programs. The idea is what's called a hub and spoke model. So for us, Broken Hill and Bourke are our hubs, and the spokes are the smaller regional towns. So these are, Australia kind of leads the field in this. We've been doing this for a long time, but they're different for different areas. They're fragmented. The funding is very random. So, it's a model that we kind of pioneered, but are still struggling to keep afloat.
Which almost leads me perfectly. I'll just got one more.
Yep. The Northern Territory ones are public funded, and so is the blood from the state, from Royal Darwin Hospital and from Alice Springs Hospital, and the one in WA, which encompasses most of the state, also is state funded. So New South Wales is the one that does not.
Which was the question I was about to ask. With the other services that are being provided, do you know the percentage of how much is funded by the state versus the Commonwealth?
I think it's the vast majority is state funded, almost complete.
Okay. Thank you for that. I'm just going to move now to the dentistry aspect, and I'm not sure how much time we've got left, Chair. Is it 5 more minutes? Yep. Trevor, do you have anything?
I'm very relaxed. I'm listening to it all.
Oh.
Absorbing it.
Trevor's like a sponge.
Can call many other things, but rarely a sponge.
We'll take that one.
I meant that in a good way.
Do you visit your dentist every 12 months? That's
Actually,
I know. Despite Trevor's dental issues, what I wanted to ask you is, when I was listening to your early testimony about the voucher scheme that you were discussing. Could you expand on that a little bit more, and how access to that might actually assist attracting more dentists to those more remote areas of the state where obviously provision of services is an issue?
Do that one?
Sure. Yep. So if there could be better collaboration in a public-private sense, it would incentivise practitioners to go out there knowing that they can make a certain income of public patients through the voucher system, and then knowing that they could also see private patients at the same time. That's not something that's well utilised out in the rural remote areas, because the voucher system is basically spread out on more of a per capita rate. So, as your population is smaller, there's going to be many less vouchers out there. Whereas in the metropolitan area, where we've got good oral health services in the public system already, they've got many more of the voucher dollars.
So how does a patient access the voucher? Is it through a GP where they would actually get a referral to the system, or is it through a hospital where they've recognised that there's an issue where they need to have certain dentistry work done, and that's how they access the voucher? No,
it's through the public dental services. So basically you go on the wait list, and once you get to the top of the wait list, if the oral health service can't provide that treatment or wants to farm some of that treatment out to the private service, they'll give the voucher for the specific items of service that they would ask a private practitioner who's participating to carry out. So it's not done through GPs or hospitals. It's not facilitated that way at all.
Okay. So I would assume then that means rural and regional people probably find it slightly harder to be able to access the voucher system, because accessing that scheme in itself is probably made more difficult through remoteness. Is that correct?
Well, we could give you examples of people driving at least 2 to 3 hours to attend a public dental clinic to find that it is not manned, and then going home with the same problem, coming another day still in acute pain, getting a voucher, and then having to find a dentist to actually do whatever therapy's been given, and they go home. So 2-3 days out of their life, the economic cost to everyone, I don't think we've ever actually calculated, but it's a very cumbersome scheme at the moment.
Yeah. And I guess projecting that forward, it's really, I would say, a Commonwealth scheme, much like the Medicare system. And is that like, it's sorry, not like the Medicare system. I mean, it's federally administered like the Medicare system. No, it's not.
No, it's a New South Wales Health.
Yep. Okay.
System.
So New South Wales Health then are providing that service, and they're providing the vouchers to for access of services, but then they can't get into a dentist because they are either booked up or too far away. So the way to actually, I guess, attract dentists out there is to expand that voucher service. And do the dentists need to have an accreditation in order to provide the service to receive the voucher?
They need to be signed up to the voucher scheme.
Okay.
Yeah.
So and are there many
accreditation as such?
Are there many dentists that are actually part of that scheme at the moment?
Yeah, there are a significant number of private dentists and our members that would do that scheme.
Okay. So in that instance then, where the dentist is signed up, the New South Wales Health has actually got the voucher that's pushed out, and they've got the is it just the fact that the dentists aren't out in areas, or what, when you say that accessing the voucher scheme is part of the holding back of distribution further out of dentists, how what changes need to be made in order to see those dentists move out to those regional areas to access those schemes?
Well, there's not enough money. So if we talk to the head of New South Wales Centre for Oral Health Strategy, he'll tell you that on the funding that they've got, there's no way that they can provide comprehensive oral health services to everybody eligible. And in fact, data shows us that about 20% of those people who are eligible access the public dental services. It largely comes down to funding. As everybody in the room is aware, Medicare doesn't cover dentistry. It's the only part of the body that isn't covered in any way. So, when you're starting on that footing, it's very difficult to provide anything comprehensive, let alone anything preventive and giving people a good start, because there's no basis on which to build. So it's schemes like that are already in existence that we would propose by additional funding. It will alleviate some of the issues, especially for rural and remote dwellers.
So
I'd also add to that, there's, as you no doubt have been told in the past, there's a fair amount of hidden poverty in rural areas. It's well disguised, but it is certainly there. Yeah. And my own personal experience is people turning up in a very, very bad way, needing dental care, and you just do it.
Yeah.
And so it's just part of what we do. But it certainly could be altered a lot to make it more attractive to other practitioners to come and make it part of their life.
So if I was to summarise it, in order to get more dentists out there using the voucher scheme, we need more vouchers.
Yes, and we're forgetting a whole other sector. So we're not just dentists. We've got oral health therapists and hygienists and dental therapists as well, who are soon to be getting their own provider numbers. So that's providing a greater workforce. So it's about working out ways to get all of these different types of dental practitioners out there and incentivising them and making their practices sustainable.
Thank you. Mr. Chair, may I, with indulge, a simple question on Indigenous ophthalmologists and Indigenous dentists. Are there programs?
Most questions are always the simplest ones.
No. Very.
So the Honourable Secretary, Please proceed, and the government write a reply if necessary. So.
No. I trust Wal.
Indigenous dentists and Indigenous ophthalmologists.
Okay, so we are at this very minute helping Indigenous dentists set up their own organisation, independent organisation. Their numbers, they claim at the moment, is about 50 nationwide, but that would include dentists and just people in the oral health field, hoping to get up to 100 by 2030, something like that. So yes, we actively engage with them. I had a meeting with them last week. Keen as mustard to get this thing going.
Good. Thank you. Ophthalmologists?
We have one in Queensland who identifies as Indigenous. We have two who have just joined training programs, one in WA and one in Victoria, who identify as Indigenous. And with our national selection, we now have 8 out of 100 points for indigeneity and a guaranteed interview. At least at the RANSCO level. So we're taking a number of measures to actively drive that. We're also looking at this regionally enhanced training network. So because we know that training people on country is a great way to go if you're Indigenous, and so we've got a top-end pathway looking at, if we can attract some Aboriginal and Torres Strait Islander doctors to commit to training in the Northern Territory and the Northern WA. Also we're aware that if you want to get people to go regionally, stay regionally, that the split model training, when you train more than 50% of your specialist training in regional areas, is 5 times more likely to make you stay there when you actually graduate as a specialist. That's why we've put together this region enhanced training network, hopefully which will also increase the number of Indigenous trainees.
Thank you.
Well, on behalf of the committee members, can I thank all 4 witnesses. It's been great to have you with us this afternoon. It's provided some rich insights into terms of detailed information that I'm sure we'll be able to use in our deliberations for the preparation of our report and recommendations. And can I also just acknowledge and thank the 2 organisations for the thoughtful and strategic work you're doing in your areas of respective health, in that it's taking us forward in looking at new ways of dealing with clearly serious issues that are there and have been there for some time. But hopefully we can make some progress over time with respect to dealing with them. So thank you very much for your great work. Thank you.
Thank you.
Thank you.
Okay, we'll now I have a short transition to the next and final panel for today.
There's a program at the University of New South Wales called Shalom Gamarada, and 25% of all the Indigenous doctors in Australia have been through the program.
Is that right?
25%.
Big chunk.
Yeah. And they get one-to-one mentoring and tutoring.
Good afternoon, it's Andrew here from the Secretariat.
Yeah, very impressive.
Ms. Hoey Thompson, can you hear me?
Fundamental to resolving some of these problems.
Okay,
Yep.
can you hear me?
Yes, thank you. And Ms. Lowry, can you hear me? Thank you.
Oh, Miss Lowry.
And
We've got
we're waiting on just a couple more.
I might just grab a coffee.
Yeah.
You're going to be extra nice today.
Nah.
Ooh, last one.
Oh, this is the last one.
Last one.
So Julia said to me, yesterday she said, let's spend the night home tonight, right? Let's spend the night home. Somebody texted me about tickets to the theatre.
Especially when you're mentally prepared to be like, okay, we're just going to...
Dr. Dalton, it's Andrew here from the Secretariat. Can you hear us?
This one.
Yes, I can.
Thank you. And Professor Perkins, are you there? Can you hear us?
I can hear you.
Thank you. Thank you for joining over the phone.
Sorry about that.
That's okay. Well, we'll get our next session underway, the last one for this afternoon. And on behalf of the committee, can I thank you all for joining us for this session. We'll get through the formalities in terms of admitting you in to give the evidence this afternoon. So that requires for each one of you to go through a procedure of stating your full name, your position title, and then swear either an oath or an affirmation, whichever you prefer. The names of which, the words of which I should say, should have been provided to you. If for some reason they haven't come through, you've not got them with you, just put your hand up and we'll provide them to you. So I've got a list of the 4 names in front of me, so I'll go down in this order. It's convenient, and we'll proceed that way. So, Ms. Lowry, could you please commence? If you could you please bring the microphone a little bit closer? We can hardly hear you, Ms. Lowry.
Sorry, I'll speak louder. Can you hear me now?
Yes, we can. Thank you. Yes, we can.
Okay. No problems. Thanks for pointing that out. I, Catherine Mary Lowry, Mental Health Commissioner of New South Wales, do solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. Dr. Hoey Thompson, please.
My name's Dr. Justine Hoey Thompson. I work as a psychiatrist. I'm here today to represent the New South Wales branch of the Royal Australian and New Zealand College of Psychiatrists.
Thank you.
And today I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth.
Thank you very much. That might have just broken up the end. Could you just repeat, Dr. Hoey Thompson, could you just repeat, can we get you to just say a couple of words? Because it just broke then. Yeah, sure. Can you hear us?
Yes, I can. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much. No, that's great.
5 or 6 words that were missing.
Thank you. Thank you. Moving on now to Professor Perkins.
I'm Professor David Perkins. I'm Director of the Centre for Rural and Remote Mental Health in Orange and Professor at the University of Newcastle. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you, Professor Perkins. And Dr. Dalton.
She's frozen.
You may be on mute, Dr. Dalton, or no? Dr. Dalton.
I'm Centre at the Centre for Rural and Remote Mental Advocacy.
We've got broken transmission.
Can you hear me?
Yes, I believe there's a slight delay, but
Trying again. Can you hear me?
Yep. Yes, we can hear you clearly.
Okay, I'm sorry. Okay.
Thank you.
So my name is Hazel Dalton. I am the research leader at the Centre for Rural and Remote Mental Health, part of the University of Newcastle in Orange. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thanks, Dr. Dalton. Well, once again, on behalf of the committee, welcome all of you this afternoon. Can I just acknowledge and thank the respective organisations for their submissions to this inquiry. So starting with the Commissioner for Mental Health, Commissioner of New South Wales, thank you. Your submission is submission 476 to the inquiry. For the Royal Australian and New Zealand College of Psychiatrists, your submission, as you would be aware, is submission 272. And to the Rural Health Research Centre for Rural and Remote Health, Mental Health, your submission is 454. So all of those have been received, processed and stand as submissions to the inquiry and have been uploaded to the inquiry's webpage. And of course this afternoon is an opportunity to add to that evidence your organisations have provided by providing some oral testimony. So what I'll do now is I'll proceed through what are the 3 groups or the 3 organisations and invite an opening statement from each, and then if you're all happy, we'll move to questioning from the committee members present at the table. Does that suit everybody? Thank you. Well, Ms. Lowry, can we please commence with you to make your opening statement?
The Commission's submission focuses on the well-being and mental health aspects of people living in rural, regional and remote New South Wales and their relative access to mental health services and well-being supports. In responding to a number of the terms of reference of the inquiry, we highlighted that all rural and remote LHDs, local health districts, have higher than average rates of high or very high psychological distress in adults. We also know that suicide rates tend to increase with remoteness. Intentional self-harm hospitalisations are much higher in regional and remote local health districts compared to metropolitan health districts. We know that data shows that a lower proportion of the population access medically funded mental health items in regional and remote areas than in metropolitan areas. And there are lower levels of mental health prescriptions in remote and very remote communities. However, there are wide variations in patient experiences and timeliness of care across New South Wales LHDs, but overall patient experiences are more positive in rural areas. The prevalence of mental health professionals decreases with remoteness, and the average hours worked increases with remoteness. The specialist workforce is important to responding to the needs of particular communities. We know that the health workforce must support and respond to the social and emotional well-being of Aboriginal people, which is that broader concept of health alone, and that we need to overcome barriers to seeking help for mental health concerns faced by culturally and linguistically diverse communities. Additionally, rural, regional and remote communities have faced compounding disaster events, drought, bushfire, floods, mouse plagues and of course COVID. The long-term events of these compounding events on mental health and well-being of regional communities is still being explored. We know over half of regional and remote communities were impacted by the drought at 57%, and half of regional and remote communities were impacted by the Black Summer bushfires, of which 16% reported that more than half of the local area was burned in the fires. In February 2020, flood and storms impacted most of New South Wales, and nearly 94% of regional and remote postcodes were declared by the Insurance Council of Australia to be in the February catastrophe event. These indicate the impacts that overall the communities in these areas experience upon their mental health and their well-being, and the subsequent need to provide services appropriately and in a timely fashion. COVID-19 has also had an impact on the well-being of rural communities. In 2020, the Commission surveyed New South Wales residents about the impact of COVID-19 on their mental health and well-being. 1 in 20 regional residents were diagnosed with a new mental health issue in 2020, compared to 1 in 10 among their Greater Sydney counterparts. However, in 2021, I've been advised that New South Wales health data shows there have been, unfortunately, an increase in suspected or confirmed suicide deaths in rural and remote New South Wales compared to the same period in 2020, and an increase in self-harm and suicidal ideation presentations in emergency departments in almost all regional and rural local health districts. The Commission is now conducting a second survey to understand the mental health impacts of COVID-19 on wellbeing and mental health during 2021. Over the development of Living All in Focus, the New South Wales Mental Health Strategic Plan to 2024, we visited over 60 communities around New South Wales, and 20 of these in regional and remote areas and regional areas of New South Wales. These consultations highlighted 5 consistent themes in consideration of mental health service delivery in regional and remote New South Wales. The first theme was access to services. That is, the desire for services to be available where people are. Easy navigation of the system, including better pathways between services and service delivery through community hubs. The second theme was funding security and challenges. Financial barriers of increased cost of services and the reported reduction in bulk billing impact community access. The impost upon smaller organisations and competitive tendering short-term funding cycles means they may not be in the best position to secure funding for their local communities. The third theme was mental health peer workforce. Increasing the numbers of peer-led services and lived experience peer workers was seen as essential to grow local services and supports from their own community. The fourth theme was staffing workforce, availability of staff, availability of training, barriers to professional development, and recruitment and retention challenges were the result of ongoing challenges overall in recruitment and training in rural and regional areas. And the last theme was the impact of social determinants. This is housing, education opportunities, drug addiction and financial assistance, employment opportunities and transport. It was really an overall picture of saying is the community strengths and resourcing the community in intervention and supporting well-being as well as mental health that was key in these areas. Having local responses where local people are part of designing those responses. So Living Well in Focus had 3 strategic priorities that really highlights and resonates with those things. The first is strengthening community recovery and well-being, strategically investing in community well-being and mental health, and ensuring the right workforce for the future. I'll leave my opening comments at that, and I welcome any questions on our submission. Thank you.
Thank you very much, Commissioner. Can we now move to Dr. Huey Thompson, please?
Thank you, Catherine Larry. I agree with everything you had to say, and there will be similar overlap with what I have to say on behalf of the college. So to the Honorary Greg Donnelly, the New South Wales branch of the Royal Australian New Zealand College of Psychiatrists, who I'm here to represent, thanks you for the opportunity to provide a submission and to appear before this parliamentary inquiry. The college is a membership organisation that trains doctors to be psychiatrists, as medical specialists. It supports and enhances clinical practice, advocates for people affected by mental illness, and advises governments on mental health. The New South Wales branch represents more than 1,200 fellows and around 400 trainees. According to the 2016 census, about 2 million people live rurally, regionally, and remotely in New South Wales, and about 1 in 5 or 400,000 of those a year have a mental illness. Some 55% of First Nations people in New South Wales live in these areas. Or twice as likely, as Catherine Mary said, to have experience high or very high levels of distress, 3 more times more likely to be hospitalised for intentional self-harm, double the rates of suicide, up to 3 times the rate.
Sorry, I missed that.
Health inequities for these people are unfair and largely they're primarily from isolation, socio-economic disadvantage, lack of healthcare providers, and barriers to service access. One of the reasons for lower engagement in healthcare is the lack of access, which requires targeted. The basis of the New South Wales branch recommendations comes from the belief that people living rurally deserve equitable access to services to meet their needs in an affordable way in continuity of care. In fact, I think that's right. Care should be as close to home as possible. This may involve innovations such as telehealth, specialist supports, local services, solutions to facilitate access, addressing transport barriers. First Nation people need to be provided with culturally safe and appropriate mental health care to address the intrinsic disadvantage. As far as the terms of reference, comparisons for patient outcomes mentioned the higher rates of suicide, self-harm and psychological distress despite the prevalence of mental illness being similar to those in cities. It's exacerbated by poor access to acute and primary care. As Catherine said, the reduced bulk billing, limited number of mental health services and professionals, and also the distance, the travel and cost for people already struggling can be significant. Alcohol and other drug issues in all populations are often comorbid with mental health issues, and harder to access help for that in rural regional communities. There's more risky smoking, more risky drinking, more use of illicit substances, including methamphetamines. And child and adolescent services has seen an escalation of presentations, particularly in COVID times, to emergency departments with eating disorders, self-harm, suicide, and psychotic illnesses. As far as the access to health and hospital services, there's reduced access to the city. There's fewer health professionals, and services might not be appropriate for the care for, say, young people or older people. Telehealth services may be difficult to access, particularly in areas with poor connectivity. and data speeds. Fly in, fly out specialists can fill gaps in the service, but they deliver care at limited times. And we've heard that there's some areas such as Western New South Wales, Southern New South Wales and Murrumbidgee areas that primarily depend on fly in, fly out psychiatrists. So rural communities have a chronic shortage of services and health professionals to staff them. As far as patient experiences and wait times, there's frequently a lack of 24-hour support and care for acute presentations at night. Many people have to stay overnight in really noisy, bright, distressing emergency departments that can access care. So the first recommendation of the college is the development of a rural and remote mental health strategy which targets those at risk of harms, Asian people, child adolescents, drug and alcohol issues, targeted fundings for suicide prevention and continuity of care, fund and support telepsychiatry and upgrades to technology, expand treatments for drug and alcohol, and a whole array of prevention, early intervention. As far as planning systems for the New South Wales Health, the branch recommends the government's rural mental health strategy consider population growth and acute care needs of the community to be met with a reliable and sustainable workforce. As far as recurrent expenditure, expenditure in mental health services per capita decreases significantly more in rural areas, and so it's grossly unequal. In fact, there can be a 700% disparity between dollar spending in the city compared to a remote area. And services, in fact, might be even more expensive to run at remote distances travelled. So the third recommendation is funding reform that's equitable across rural LHD services. It acknowledges the population growth and also the significance they show economic disadvantage. The final aspect I'd like to comment on is the staffing challenges in these areas. So the distribution of mental health professionals rapidly decreases with remoteness. Psychiatrists are 6 times less prevalent, psychologists 5 times less prevalent remotely, and mental health nurses 3 times. The issues are complex of why this is so, but one of the reasons is the lack of flexibility of the New South Wales government awards, with no capacity to provide financial incentives in hard to recruit areas like growth areas. So there's a need for the consideration of the lack of flexibility in the award. And just as a final comment from myself, the shortages in workforce are not just, I heard yesterday that Walgett Hospital is workforces, also in more non-regional areas. So today I heard of someone in rural ED department of health in illness who's been there for 96 hours waiting for a bed. Meantime, there's 16 beds that aren't being used in our health district because they can't be staffed. So I think that is a great disappointment. There's still a lot of suffering in some instances.
Well, thank you, Doctor. That was a very comprehensive opening statement for and on behalf of the college, and I'm sure that will lead to some questions from members shortly. Moving now over, Professor Perkins, can I invite you to make an opening statement? Was that the plan, or was it going to be Dr. Dalton, or both?
It's the plan.
Okay, thank you.
I'll be the inspector if that's it. Thank you very much, Chair, and I apologise for being on the phone. It's an example of rural internet difficulties. I'd like to start by saying that I strongly support the comments that have been made by my 2 colleagues, and there's been a significant change since we submitted our evidence. So since we submitted the evidence that you have before you, the New South Wales Government decided not to continue to fund the Centre for Rural and Remote Mental Health in New South Wales. And so we're no longer funded by the New South Wales Government. And after 20 years, the physical office will be closing on the 17th of December. A small team of about 7 will work remotely to complete externally funded research projects, such as the impact of the pandemic on rural and remote mental health, which is being undertaken for the National Mental Health Commission.
Professor, sorry to interrupt, Professor. Professor, sorry to interrupt. Just wondering, just tell me, how long had that been operating for?
For 20 years.
Thank you. Sorry.
In Orange.
Thank you.
We can provide further information on any of the points we made. In broad terms, the prevalence of mental health problems in rural and remote New South Wales is similar to that of the large cities, but we do have a series of stressors such as fire, flood, drought, mice to a much greater extent than takes place in cities. We conceive this as a form of rural adversity, which is sequential, which is cumulative, and which overlays the adversity of normal life that individuals contend with, such as a cancer diagnosis, a child with a learning disability, an accident, all those sorts of things. We know that over very many years, rural and remote suicide rates have been consistently higher by up to 50% than those in the cities. And we know that self-harm rates are also elevated, particularly amongst young people, and that COVID has, as the Commissioner told us, has led to some increases in New South Wales. We know that most available data is provider data, health service data, and it implies that people have managed to access services. Community data such as the 2007 National Survey of Mental Health and Wellbeing or the Australian Rural Mental Health Survey is crucially important because we need to include those people who are not currently receiving services as well as those people who actually manage to find their way to the front door. We know that access to mental health services is a problem. In rural areas such as Orange or Dubbo, there's a shortage of specialists, of psychiatrists, of clinical psychologists. When you get to remote areas, there's also a shortage of resident generalists, of GPs, of nurses. So it's really very difficult for those in remote parts of New South Wales. And we know that access to mental health services declines with remoteness. Less money is spent on those people from the NBS and PBS systems, and it's a major equity issue. We know that rural communities are highly variable and that one service model will not fit all. The model for Wilcannia will not be the same as the model for Lismore. Services are made up of private, public, Aboriginal, NGO and philanthropic staff, supplemented by visiting clinicians and a wide range of mental telehealth programs and services. And the key to effective rural services is the way in which these providers collaborate. And collaboration has a time and a resource cost, which must be accounted for and supported. This enables the ability to build trust and to build continuity. And the constant cutting and changing of services that is not good for trust, it's not good for community capacity, and it's not good for outcomes. We know there's a digital divide. Some rural residents are excluded from many of the teleservices by poor internet access, poor skills or capability to use those services, and sometimes they're trying to use services from a place that is not safe. In our view, the most effective services are those that have been designed by local communities working with the full range of community members and service providers. These have been made to measure, as it were, for those communities. Over the COVID experience, we know that frontline responses, whether they're health service, police, or any of the others who come to see people, have been suffering increased anxiety, increased depression, higher burnout scores, and that many have announced an intention to leave and to find other employment. So the pandemic has taken a significant toll on the people we wish to provide these services. And we believe in conclusion that it's critical that we focus on developing and supporting the workforce, and this will require effective and sustained collaboration between governments, between training providers, between colleges, and between service providers. And that this workforce that supports the system includes clinicians, but it also includes other professionals, peer workers, managers, and those in service planning, design, training, research, and evaluation. It's these people working collaboratively that will make the system more effective, or where the big holes will appear. Thank you very much.
Thank you, Professor Perkins. That was equally a very comprehensive and detailed opening statement. Just out of interest, just for my knowledge, just where are you actually calling from, Professor Perkins? Just where are you located?
in a general
I'm
sense.
currently calling from Orange because my office has no internet working.
Okay.
So I'm trying to operate from home.
Okay, no, that's just
Wasn't a criticism.
no, it's not a reflection on you. We're having these breakages, and it's just out of interest for me anyway. Whereabouts people are located, so appreciate that,
Mr. Chair.
The Honourable Walsecord.
Professor Perkins, can you tell us a bit about the Centre for Rural and Remote Mental Health, and why is it closing on December the 17th?
We were set up in up to about 2000 by Professor Beverly Raphael when she was the mental health director in New South Wales. And the basic case was that, with the greatest respect, people sitting in the middle of Sydney don't see rural mental health problems in the same perspective of people who live and work in rural and remote New South Wales. We've had a series of of short-term contracts of 3 and 5 years for that 20-year period, and our last contract ran out at the end of December last year, December 2020, and we've been through 6-month and 3-month extensions. But the previous contract was to have a centre for rural and remote mental health. What we've led were 2 service contracts. And so essentially we are in the physical process of closing the building. The library has been dispersed, and a lot of the staff have moved to essentially other jobs in other industries.
How many people were there providing services?
There were around 20, and we're now down to 7. I'm stepping down on the 17th, and Dr. Dalton and a small group will be completing activities through to June the 30th.
And what will happen to the people who are accessing your services or getting support or the programs? What will happen to them?
Yeah, what will happen will be that there will still be rural adversity mental health workers who will be out in rural and remote New South Wales and employed by health districts. What will be lost will be 2 things. One will be the development, coordination, and training of those people, which we've been doing. The second will be the independent research or quasi-independent research, which is about trying to understand the key issues of rural adversity, the impact of fire, flood, drought, and those things. Secondly, the issue of rural suicide. Thirdly, the issue of rural services. And fourthly, the issue of, as it were, community development and addressing the social determinants of mental ill health and suicide.
Professor Perkins, it couldn't have come at a worse time, could it have?
No, and it's been a slow burn because myself have been working on trying to address the refunding issue since the beginning of 2020. So it's been a long period of uncertainty. And, how can I put it, loss and stress.
Thank you very much. Dr. Hoey Thompson, you mentioned in your opening statement a patient waiting 96 hours for a bed. Which hospital was that? Lismore Hospital, 96 hours. Was that a recent development, or when did that occur?
It's now.
It's
today.
Today. A person is waiting 96 hours in Lismore Hospital as we speak. Why is that? I'm not blaming you. I'm just asking the question, why is that occurring?
So there are, I think there's 85 adult mental health beds in LHD.
Yep.
16 of those are unavailable because they can't be staffed. Doctors, nurses, health, they're not available for use.
So there's no staff there. So what is happening to the patient? Is the patient just sitting on a chair in the emergency department?
I don't work in that particular hospital anymore.
Yeah.
So I assume that they're either in a room by themselves or have I don't know precise details.
Well, that's
Too much on individual people.
No, I understand that.
Yeah,
A mental health commissioner, Catherine Lowry. Now, you mentioned that you've done consultations around the state. I think you mentioned from memory 60 consultations around New South Wales. Is that correct? How many in rural and regional areas? Sorry, you're muted.
Or very faint.
Oh,
Yeah.
sorry, I'll speak louder.
Yeah, come a little bit
21.
closer to the microphone, please, yes.
Sorry, what was the answer? Sorry.
21.
21, right. Now, Ms. Lowry, you remember some time ago when, I think it was several years ago when you were appointed mental health commissioner. Have you met the new premier?
Yes, I have.
Oh, you have? Okay. When did you meet the new premier?
I met him when there was an announcement of mental health funding 4 weeks ago. I can get back to you with the exact.
Okay, could you take that on notice? Because I'd like to know, when you met the premier, did you raise with him concerns about the Centre for Rural and Regional Mental Health closing on December the 17th?
No, I didn't.
Have you raised it with the health minister?
No, I have only been recently appraised of the closure of the centre.
Do you support the closure of the centre?
I would say that we've had a really good working relationship with the centre.
Mm-hmm.
The Commission has not been involved in the procurement process that ended up in a different tendering outcome for the service. So the Commission is really interested in establishing new relationships with the new provider, but we hold the centre and its employees in high esteem, and we have worked.
I'm sure you hold them in high esteem. What about the people receiving the services, receiving the training? What steps have you taken to ensure that they're not going to be disadvantaged? So you'll have to speak up, Commissioner.
Oh, I'm so sorry. The Commission doesn't have a role in providing services, or that's really the.
I wasn't asking about providing services. I meant supporting those who are providing the services. So I'd assume that you'd have an interest in the Centre for Rural and Remote Mental Health continuing to operate.
I absolutely have an interest in having those services continued.
Mm-hmm.
I don't know the details of the new procurement, so I'm not in a position to understand what services are being transferred, and I have asked for some advice on that.
Mm. Now, it's been put to me and to, I was Shadow Minister for Health for 7 years, and 5 of that mental health, that having access to a psychiatrist in New South Wales, particularly outside of Sydney, Wollongong, Newcastle, is a luxury. What do you say to that?
I think we know from the evidence that previously from the college rep that absolutely access to psychiatrists outside metropolitan Sydney is difficult.
Right.
And even if we look at telehealth, telehealth modalities don't always suit individuals.
Yes.
And so how can we get local services that can support people and support people to even become more familiar with telehealth? But it's not only about psychiatrists, of course, it's about the team and the mental health team that are there also on the ground in towns to support individuals in their recovery in the mental health journey.
Right. We've had evidence from Indigenous people from the Indigenous First Nation community concerned about, very uncomfortable with telehealth. How do you grapple with First Nation people who are uncomfortable with telehealth in general, and then layer that on top with having to deal with mental health problems? How do you grapple with that?
When the Commission did its consultations,
Yeah.
we had a particular stream of where we sat with Aboriginal people, and we asked them what they would want.
Mm-hmm.
And it was about having Aboriginal psychiatrists, Aboriginal trained mental health workers working with them on country preferably. And I think that's something that in the recommendation that the college made about having a rural mental health plan is looking at how can we grow Aboriginal workforce.
No, I understand that. In fact, I think there's one New South Wales Aboriginal psychiatrist, and I know him. So I think there's one in New South Wales. Now, can I take you to the issue of what's seclusion involving, as a KPI indicator, the use of seclusion involving mental health treatment in New South Wales? What is seclusion?
The definition of seclusion.
Well, I sort of know what it is, but I want you to say what it is.
Oh, okay. Seclusion is the placing of a person in a room or a location where they have no access or egress from that. So they have no ability to leave that space.
No freedom of exit. No freedom of exit. Exactly. Yeah. So why are you concerned that the top 10 hospitals in New South Wales that use seclusion as a response to people suffering from mental illness episodes, Broken Hill, Maitland, Lismore, Port Macquarie, Wyong, and I put Wyong in there, but that's actually the Central Coast, so I'll drop Wyong off. Why is that becoming because of a lack of workers, lack of staff, workforce issues, that seclusion is now becoming an issue in rural and regional hospitals?
The use of seclusion, I totally support the decline of the use of seclusion to eliminating seclusion. Seclusion should not be tolerated. And I think there needs to be in parallel other opportunities that are about providing alternative locations of care, to have improved education and training of staff, to have improved availability of training, and to have peer workers appropriate to that community, and say that, referring to your earlier question about having Aboriginal peer workers who can be in emergency departments or in other crisis environments to support people so that they don't need seclusion, but also to support the mental health team around that person.
My last question, 10.7% of mental health patients in Broken Hill Hospital are subjected to this treatment, are subjected to being locked into a room alone as treatment. Is that acceptable?
Seclusion isn't acceptable. Seclusion, especially for people who may be, in that case, at that hospital, and I've been to that hospital and I've been to that inpatient unit, especially with Aboriginal people, we need to have very culturally appropriate responses. We need to have teams that understand and embed responses that are early when people are feeling distressed. And I think there is a national commitment to that. But in rural locations where we've already heard about staffing difficulties, we need to have a focus on that, because it's not only about seclusion, it's about the re-traumatisation of people. So we want people to approach mental health services not being fearful that they may be further traumatised by seclusion. I think that's a really important point.
Thank you, Mr. Chair, and I would love to have another session on mental health if we could have that. I think we should consider that.
Thank you. Thank you. Thank you, Commissioner. We'll now move to crossbench questions. The Deputy Chair, Honourable Emma Hurst.
Thank you. And thank you all for coming today. I might throw to either Professor Perkins or Dr. Dalton. In the submission, you make the point that having a good, stable GP in the community is essential, and that people in rural areas are missing out on potential mental health diagnoses because they don't have that regular access to GPs, or might not even have a regular GP at all. Can you sort of expand on the effect of that in regards to mental health services? And I'd also just want to put the question forward whether you think that the situation is going to get worse with the close down of the centre.
Dalton, do you want to?
I could do it, David. Thank you. Look, in terms of general practitioners, in resident communities, GPs are the heart of health. They're the gateway to access to specialists. They provide mental health care themselves. So having a delay in access to general practitioner is a delay in access to care. It potentially leads to the exacerbation of the condition, and it reduces costs. So if you're going to see a psychologist, if you see a GP, you get a referral, you get a MBS subsidy to see that psychologist. And obviously, if you need to see more, to see a psychiatrist, you will definitely need to see the GP. So I think what it does is it adds delay, and it adds continuity. It can lead to a lack of continuity of care. So mostly what you run the risk of is an escalation in the intensity of the illness and delay in terms of getting treatment. And in terms of how the centre impacts it, our opportunities have been around researching what the good models of care are, where the successes are, and being able to share that with other rural communities where we know care works effectively, integrated care models like out of Mudgee, slow, quiet work that gives the models that work in the country as opposed to the city ones getting rolled out this way.
Can I make one other comment there?
Please.
That is, very often physical and mental health problems come together, and the GP is actually able to address both sides of the problem, which is critically important.
Yeah, definitely. In your submission, you also pointed out that telehealth should be an adjunct to, not a replacement of, local primary care and mental health services. Do you feel that there's a tendency for telehealth to become a replacement for face-to-face mental health services? Or is there concern that that's where we're moving?
I think telehealth is an essential component to the system. One of the risks is in how we do it and what it does to resident services. So if it comes in without regulation or consideration to the resident workforce, you can have a situation wherein the resident workforce may not have enough work to be a sustainable business. If you're a psychologist, you have to run on hours, and you've got time and costs, and there are a lot of things that go on. So if we eviscerate the rural workforce by supplanting the telehealth, you end up with no resident support. So it's important to consider how telehealth is used and deployed. There are some really great models where the specialists are brought in with community mental health and things like that. There are ways that it's an absolute boon and an enhancement. I guess the other thing that comes into play as a risk with telehealth is who's providing the support. If you're visiting a psychologist who's a resident and knows your area, they're quite familiar with the general challenges of being out in the country, what someone might be contending with, and there's a resident continuity with your experience. And so that might be another aspect in terms of best practice and care and understanding.
In your submission, you also talk about that there's a missing middle in rural and regional areas where patients' needs are too serious for a GP, but not quite at the point of requiring the state mental health care services. Can you help us just sort of unpack this a bit more to understand sort of what services are needed in this middle group to prevent conditions getting worse?
I can speak somewhat to it. I guess it's probably not strictly just rural and remote, but it's one of the things in rural and remote where workforce is an issue and servicing becomes a challenge. But what you have is people with potentially, serious but episodic mental illness who are not at acute phase. The thing around what is support whilst they're well to stay well. So that's one aspect. And there is also when someone has a moderate to serious mental illness but may not need to be an inpatient. And work funded health services and EBS people services can declare them too acute or too serious for their model of care parameters. And then when you go to the LHD, community mental health and mental health say, look, you're not serious enough to be in hospital, we don't have anything for you. So it's that gap in care and around who's holding whom and what. How do we get responsibility so that there's actually overlap as opposed to a gap? So it is about encouraging the responsibilities to extend into a proper handover and cover over, as opposed to you're not difficult enough for me or too much for my service. So that collaborative care and actually good collaboration between services so they actually make sure people don't fall in the gaps.
Thank you.
Thank you very much. Kate Fairman.
Thank you, Chair. My first question is to Ms. Lowry. This morning or earlier this afternoon, we heard from, this morning, Just Reinvest, who brought to the committee the really unacceptable link between undiagnosed, unaddressed and untreated cognitive impairment, mental ill health and trauma amongst young Aboriginal people going through the youth justice system. And I asked the witness for Just Reinvest about whether there was any statewide programs to really try and address this issue with vulnerable young Aboriginal people. Is there a statewide program in terms of mental health, particularly for the most vulnerable, to try and address that issue before they enter the criminal justice system? Is there any statewide programs you're aware of?
Of those, I could find out, but that would either be from the Justice and Communities Cluster or from the Justice and Forensic Mental Health Network.
Do you think this is an issue that needs to have a lot more consideration and attention given to it then?
I think that when we look at the overrepresentation of young Aboriginal people in our custodial system and in our forensic system, I think it is absolutely a priority.
I wonder if any of the witnesses from the Centre for Rural and Remote Mental Health have anything to contribute in that regard in terms of particularly young Aboriginal people and mental health issues, seeing if anything can be addressed at a level or extent before they enter the criminal justice system, whether there's any recommendations around programs or whether there's been any successful trials or what have you that you have any knowledge of.
I'm not an expert here, but I think it would be worth looking seriously at the Justice Reinvestment projects in Burke. The broad idea being that we spend an enormous amount of money incarcerating people, and if we could use some of that money to provide them with care and with educational and employment and support opportunities, it would be a much better situation.
Yeah.
I mean, it does sound, thank you, it does sound like this is just like obviously an enormous gap. The statistics are just horrendous in terms of the difference between the rate of mental health issues for young Aboriginal people who enter the criminal justice system is just extraordinary. So it's just, yeah, the people that, witnesses that we've asked just don't seem to, there just isn't anything in this space where it's just so obvious, the connection. It's so obvious what's happening here. But no, there is nothing. Maybe that we could do a recommendation on that.
Justice Reinvestment Project, which David referred to and the team who presented, so they did work in both Burke and Cowra. I think the approach they've taken is really about addressing the social and emotional determinants of mental health and wellbeing, so taking a holistic approach with their Aboriginal youth. And they've got good data on how well it's worked.
Okay, that would be good. Maybe we'll find out a little bit more about that actually for this inquiry. Thank you. I'll again with the Centre for Rural and Remote Mental Health. In terms of your submission, you have a particular criticism of market-driven responses for rural areas, particularly that the significant fragmentation and duplication of rural mental health services. We've heard a fair bit about that, in fact, but not just mental health services, in fact. Could you just explain to the committee a little bit more about why you see that as a particularly, you wanted to draw our attention to that?
Yeah, I think because, the whole issue of fee-for-service services in this area implies that, on the one hand, there is a demand sufficient to enable a psychiatrist or a psychologist or an occupational therapist to make a living. And it implies that, that there are a range of, it is possible that works to some extent in the cities, but that really doesn't work in small rural places where there is not a sufficiently sized population to pay for specialist services. And that goes right across the board. That's why you don't have barristers, living and working in these places. That's why they visit, the market. So we have, as it were, thin service systems. And that does also raise the point that Dr. Dalton made earlier, namely that a city-based telehealth service may actually take away, particularly if it's provided free, may take away the market for a resident psychologist, occupational therapist who lives in a rural area.
Yeah.
So we have to look at it from the perspective of the consumer and the patient, and we have to look at particularly from those who cannot afford to pay market rates for these services because they are on New Start, therefore they're disabled, whatever it might be.
Professor Perkins, just my last question, if I may. So do I understand with you lost a contract, is that correct? I think Ms. Lowry referred to that the services being provided by yourselves have actually been contracted out to another organisation. Is that?
There was a change in contract. We were contracted to run a physical centre for rural and remote mental health. What happened was that after a long period of uncertainty, two contracts for support services were let, and those contracts were awarded to groups based in Wollongong. We can provide more information if that would help to do.
No, you're now cutting into my time.
No, I'm just saying thank you. Yeah.
Sorry. It's just an open competitive tender for two different, so one was to manage the Rural Adversity Mental Health Program, which we formally developed and met, and the other was for a Rural Mental Health Research Partnership, which is distinctly different from what we have formally been funded to do. So whilst there is an investment going forward, it's not the same as it was before, and financially it is less as well. We didn't get it, it went to the Peregrine Centre at Wollongong.
Okay, thank you.
Thank you very much. We now move to questions from the government members. The Honourable Trevor Khan.
Well, that last answer in part answers part of the question. It's the case, isn't it, Professor Perkins, that the Rural Mental Health Research Partnership tender went to the Peregrine Centre, which is based essentially around Wollongong University. That's correct, isn't it?
Yeah, absolutely.
And the other part of the contract was with regards to the management and coordination of the RAMP coordinators, and that was awarded to Grand Pacific Health.
A private provider.
That's correct. And the 19.5 RAMP coordinators continued on in employment now under the control of those of Grand Pacific Health. That's correct, isn't it?
No, they're under the control now of health districts.
Well, I try to be careful. Their employment might be with, but their management and coordination is through Grand Pacific Health. Correct?
Yeah.
Yes, it's a partnership.
That is a contentious.
Is it, sorry, 19.5 full-time equivalent. Is that what you meant? You didn't say that.
Yeah.
19.5 FTEs.
Yeah. Well, it might be contentious for you, Professor Perkins, but that's the case, isn't it? The 19.5 that existed before still existed, and you're aware that they're funded through until June 2026. Isn't that right?
Absolutely, yes.
Right. So in effect, there's no impact on that area of services at all, irrespective of your involvement in it or not. Correct?
That remains to be seen. But the resource levels may be the same, but the impact will remain to be seen.
Well, I can understand as an unsuccessful tenderer, you're not going to be particularly happy about it, but it was a tender process that was overseen by O'Connor Marsden and Associates, was it not?
As we understand, yes.
Yeah, and there was an independent probity advisor as well.
Probably don't have it to hand.
Yeah.
Sorry, I didn't hear that last answer.
No, sorry, I didn't quite hear that last observation.
Dr. Dalton.
There was a tender, but that's correct, yeah.
Yeah. All right, look, I think it's just been important to make quite clear that it's not simply been an exercise of closing down and there being nothing. There has been a different strategy that's been adopted, and unfortunately you were the unsuccessful tenderer in the process.
Yes, but I guess the point I was trying to make was that the previous contract was to provide a physical centre for rural and remote mental health. The current contract is 2 contracts for services, and that's quite different.
Well, one is a contract for research, and the other is a contract for services, is it not? Yep.
Yeah, sure.
Sure. All right. Look, I don't have much more, but if I could go to, if I can go...
How about Lismore? Why don't you clean up Lismore now?
I'd love to, but I can't tell you that yet. Dr. Thompson, Dr. Howie Thompson. I'm just wondering what the college has done with regards to the issue of, what do we describe it as? Training?
Seclusion.
The testing.
Yes, the testing of
final graduates
of trainees.
Oh, I thought you were talking about seclusion. Sorry.
There's been a problem in terms of those seeking to become fellows completing their would it be a correct accreditation process?
So there was a whole cohort of senior psychiatry trainees who were sitting a particular exam, and the digital technology failed, and so they were all prepared and were unable to complete that exam. So actually, I'm not sure where the college is at. I actually work as a clinician in a rural area, not in the centre of the college. So
this is not a criticism of you or the college. Yeah. This is not a criticism.
No, that's okay. So I think they're trying to find other ways to permit those trainees to progress. They know that there is extreme need for those trainees to get on with their lives. There's also a lot of unmet need for people to see psychiatrists. We need more, and they're looking at that now. But I don't know the actual answer.
Right. Could you take it on notice and see if we can find out, get some sort of schedule as to when we might see an end to the problem?
Certainly.
Yeah, thank you.
Thank you.
Bang.
Thank you, Chair. I just wanted to take up the first part of the Honourable Trevor Carr's questioning when we talked about the 2 contracts. Professor Perkins, the research that you were conducting into mental health, that was predominantly based around the Orange region, is that correct?
No, that covered the whole of the state, and we, for instance, have done work over many years that is right across the state, ranging from work in the bushfires in the south to Lismore in the north to the west and far west. So, yeah. So, did you have employed researchers in areas across the state? Is that how you operated? No, we didn't. We largely had researchers employed in Orange who travelled on the basis that research these days is usually done with teams, and it requires, getting together a team with a set of skills that you can, conduct serious research. And the lone researcher is a very unusual beast these days. No, I understand that. Is it your contention that the research contract will vary at all from what you were providing to what is currently being adopted now? I think, we will see how, having a small group and building a new group operates. My view on this would be that it takes, 5 to, 10 years to build a good, effective research groups based in rural areas, and that groups based in Wollongong have various opportunities of size and scale that are not available to the same extent in rural areas.
So can I just clarify then? You're not saying that you think that there is going to be a detrimental impact in the research component under the new contract?
No, I don't know. I don't know. What I'm saying is that it was for less money, that there is no physical centre, that a 20-year mental health library has now been dispersed, and that I felt it was important for the committee to know that while when we gave written evidence, that was the state of affairs. The state of affairs has changed. I mean, from my perspective, it's clearly disappointing to essentially see a team of about 20 basically going off and joining other industries, given the challenges and problems we have in rural mental health.
But it's true, isn't it, that your researchers were all based in Orange, whereas the new contract has a number of research positions located all across the state in order to do that research. Is that correct?
I haven't seen the new research contract, because obviously it was a tender process.
It's Wollongong. It's Wollongong.
It's a call for distributed part-time
lovely.
workers at 8 to 12 hours per week.
So when you say Wollongong, are you aware that a lot of the researchers are actually employed in places like Griffith and Abercrombie in the far west, Scone, Katoomba, not just in Wollongong? Is that? They actually, yes, they actually are.
Can I? Well, listen. I think I understand the line of questioning, but I think you've got the advantage of having some document with detail in it about where people are working.
I know, and I'm sharing it with you. I'm sharing it with you and the witness.
Well, hang on. I don't think it's reasonable and fair. This is not the way in which we deal with witnesses, with the greatest respect. I mean, information, if you've got a document, give it to them. The professor,
they're not getting my documents.
Order! The associate professor has said he has not seen the details. You're playing a bit of a game, Honourable Westvang. I don't think it's fair to treat witnesses like this. That's the point I'm making.
Not my role, Chair.
Well, I think you are, okay? I think we always treat witnesses with respect and fairness. You're obviously playing a bit of a game. I don't think it's reasonable.
I'd reject that,
I don't think it's reasonable.
I would reject that, Chair.
If you've got a document to share with them, share with them.
No, it's my document.
But don't play a game of ping pong with them, okay?
I do my own research. I'm just asking the question because I just want to make sure that.
Well, I'll continue on and raise issue with the way in which you're going about doing this. There is ways like the Honourable Trevor Khan pursued by asking questions and going back and forth.
Trevor's much more professional than I am, Chair.
Well, I think that, you'll be down by your own words. That's what you just said, okay?
No, that's fair. That's fair.
So the question is, if you've got a document to share with the witnesses, let's do it and do it fairly and let the questioning go back and forth. That's my only point.
Could I say this, Chair? I think the observation that's been made by Walt, Mr Secord, is correct. I anticipate in the further hearings there will be an opportunity for some matters to be further explored. Clearly how the Peregrine Centre operates is going to be of interest to the committee, and I think it's quite reasonable.
I was going to move that in the deliberative.
I think it's quite reasonable that we look at how that works at that time, and I think we'll have the opportunity to flesh it out then. So
I have no difficulties, but as you'd appreciate, I hope that was not the point I was doing.
No, I do agree. I do.
Okay, well, that brings us to the conclusion of this afternoon's final session. So can I thank all the witnesses very much.
Thank you.
There may well be, in fact, there probably is going to be some questions on notice, or supplementary questions arising from this afternoon's questioning. So they'll be provided to you and the Secretariat will liaise with you accordingly. So once again, thank you all very much for your participation, both through the submissions and the oral testimony this afternoon. Thank you.
Thank you.
Thank you.